नमस्ते to all the lovely doctors of this country. इस देश के इतने बड़े डॉक्टर्स को डॉक्टर विनीत गुप्ता का 12 दिसंबर की शाम 6 बजे का प्यार भरा नमस्कार. All the lovely doctors, as we all know that we are here just to figure out what can be the important questions from surgery in the upcoming FMG exam. So, a lovely good evening, beta. Indra, Mohammed, Shubham, Rohit, everyone. Naresh, Hariom, Deepak, Krishna, Ankit, Rahul, Paras, Brigu, Shakib, Roshik, Parmar. Lovely, lovely good evening to all the lovely, lovely doctors of this country. Just a small note from my side that because your exam is exactly 1 month away, we are just 30 days away from your exam. So keep yourself positive, stay pumped up, stay consistent. And let me remind all the great doctors, even if any one of you does not remember all 19 subjects at this point of time nicely, it is absolutely natural to happen. So do not get frustrated, do not get any negative thoughts that you are not able to recall, you are not able to remember, because this is going to happen. You need to keep on doing your consistent efforts. अपनी कोशिश में कोई कमी नहीं होनी चाहिए बेटा. The way you have worked hard for last so many months, they are definitely going to give you a great impetus. And if you maintain this consistency in the coming 30 days, nobody on this earth will have the power to defeat you. Remember my words. And you have to make this happen not only for yourself, but for your parents as well. Right, beta? Lovely good evening, Komal, Syed, Ashish, Sandeep, Gautam, Aijaz, Rajibul, good Dr. Bhavik. Lovely good evening, Bhavik. I hope you are doing great. Nan, wonderful. Right. So what I have tried to do in this 25 most important questions, beta, I've tried to take certain questions from pediatric surgery, certain questions from adult surgical problems, certain questions from oncosurgery, and few from trauma, vascular, and endocrine surgery. Prem, lovely good evening. Savan, lovely to see you all, beta. Mayur, Avinash, Jeet, Monishkar, Amit, Afzal, Yogesh, Manohar, Dhirendra, Yashwant, Sandeep, Piyush, Surya, Hafizur, Sagar, Ajay, Jay, Shubhangi, Sachin, Rajesh, Purushottam, Siddhant, Muskan, Ram Kumar, Indrajit, Shan, Ashraful. Lovely good evening, beta. It's really wonderful to see all of you. Naresh, Larim, Lakpam, Arpit, Pranav, Ankush, Abhishek, Prajwal. Lovely, beta. So let us straight on start and let us see how we actually deal with these situations. Okay, beta. So starting with the very first question from pediatric surgery. All the lovely doctors, yes, a newborn baby presents with excessive salivation, choking, coughing during the first feeding attempt. A nasogastric tube is passed and there is coiling in the upper pouch on X-ray. What is the most common associated anomaly in this condition? Yes, lovely doctors. Love you too, Abdul Bita. Namaste, Yogesh. Lovely good evening to Akshay, Akshata. Wonderful, Hemang. Great. Yes. Oh, so Tausif, everyone is focusing on A. Okay. Oh, everybody is focusing on A. Let me just see. This is just a moment. A newborn baby presents with excessive salivation, choking, and coughing during the first feeding attempt. That means as soon as the baby was given the first feed, maybe the mother's milk, there was excessive salivation, choking, and coughing. Nasogastric tube was passed and it was coiled in the upper pouch on X-ray, beta. Upper pouch. Now, what is this upper pouch story? Arpit, Abhishek, Okay, Medico, Ramesh, Surya. Okay. So, beta, what is the most common associated anomaly in this condition? Now, congenital diaphragmatic hernia. In congenital diaphragmatic hernia, the stomach and the intestines may come up into the thorax, which will lead to basically difficulty in breathing, and there might be some coughing type of sensation also, but generally it won't be associated with that excessive salivation story. And a nasogastric tube is passed and it is coiled in the upper pouch. Now, coiling of the nasogastric tube, see how the examiner has just created this keyword. The coiling of nasogastric tube, yes, wonderful, Nikhil. Great. So, there was coiling of the nasogastric tube in the upper pouch. For example, if we take a look here, as all the lovely doctors can see, there was coiling of the nasogastric tube in the upper pouch. And now all the lovely doctors I can see. Thank you, Akash. Thank you so much, beta. Right. So this is most likely a case of esophageal atresia. Right. The key word here in the question, as you can see, there was coiling. The nasogastric tube is passed and it was coiled in the upper pouch. Now he's not asking what is this pathology. He's asking what is the most common associated anomaly in this condition. So if it is a case of esophageal atresia, then all the lovely doctors watching this session right now, they know that esophageal atresia is associated with VACTERL, wherein V stands for vertebral, A for anorectal, C for cardiac, T for tracheoesophageal fistula, R for renal, and L for limb defects. And out of this VACTERL association, beta, the commonest anomaly what we see are the cardiac anomalies. And in the cardiac anomalies, we can find ventricular septal defects, we can find patent ductus arteriosus, AST, and even tetralogy of Fallot. Right? So, right. Wonderful, beta. Brego, Aniket, wonderful. Right? So, the correct answer for this question will be cardiac anomalies. Though anorectal, renal, all these anomalies can also be associated, but most commonly we see cardiac anomalies. Wonderful, lovely, great. So a big round of applause for all the lovely doctors who have answered this correctly. Sagar, Akshay, Happy, Ankush, Monishkar, Dopamine, Surya, Divya, everyone better. Let's move on to another question. Now, as we all know in our discussions that age is just a number but not for the MCQs beta. तो जिस भी question में उम्र दी गई हो, any question where age is mentioned, don't take it lightly. There is something specific. Like in the previous question, it was a newborn story. Here it is a 2-year-old child. Okay. Now let's see beta. Okay. A 2-year-old child presents with recurrent urinary tract infections and a palpable abdominal mass. Okay. 2-year-old, recurrent UTI and palpable abdominal mass. Okay. Ultrasound reveals a horseshoe kidney. Which of the following finding is usually seen in such cases? Okay. So let's see what is seen in horseshoe kidney. Oh, lovely. Sandeep, Saurabh, Ashutosh, Jay, Mohammed, Nan, Kumar, Vanita, Runa, everyone. Perfect, beta. Lovely. So all of you have answered this correctly. That's a big, big round of applause for all the lovely doctors. Great. Now, both the kidneys are in the lumbar region. Why this is not the correct answer, beta? Because in case of horseshoe kidney, it is a pair of ectopic kidney. Both the kidneys are lying in the lower abdomen. They are not able to reach to the lumbar region. Isthmus in horseshoe kidney is lying at the 4th lumbar vertebral level. It is not commonly associated with polycystic kidney disease, and it is obviously not associated with renal agenesis. So all the lovely doctors, if you see, this is how the polycystic kidney, this is how the horseshoe kidney can be seen. I hope all of you will be able to make out if this image is given in the exam. And if we look at the important keywords regarding this. Horseshoe kidney is a congenital anomaly where the lower poles of the kidneys are fused, forming a horseshoe-shaped structure. It is the most common type of renal fusion anomaly, and it is often detected incidentally during evaluation of other conditions such as recurrent UTI or abdominal masses. Both the kidneys are not in the lumbar region, they are in the lower abdomen with the lower poles fused in midline. Isthmus is at the level of fourth lumbar vertebra. Polycystic kidney and renal agenesis are separate congenital anomalies and not directly related to horseshoe kidneys. Key points for us: horseshoe kidney is frequently asymptomatic, but it predisposes to infections, obstruction, and stone. Always consider uretro-pelvic junction obstruction in the differential diagnosis when evaluating a child with recurrent UTI and hydronephrosis in the context of horseshoe kidney. And early diagnosis and management are definitely critical. Right. Now, another question, Vita. 1 year old. See, in the clinical questions, 1 year old male child. 1 year old male child is brought to the pediatric outpatient department with history of undescended testis on the right side. ठीक है बेटा, तो 1 साल का बच्चा है, undescended testis है right side में. On examination, right testis is not palpable in the scrotum or inguinal canal. Which of the following is the gold standard? Gold standard approach in localizing such undescended testis. Okay. Wonderful. So this is a clear-cut case of undescended testis. The examiner has clearly specified. Now let's see what is the gold standard approach. Shivansh. Okay, so we are getting answers A, D, B. Okay. Okay, so we are not getting C as any of the option, as any of the answer. Okay, beta. Now let us try to figure out how to approach these type of questions, beta. This is a clear-cut case of undescended testis. And what keyword examiner is saying? यहाँ पे गेम क्या है बेटा? गेम खेलना कैसे है? वो कह रहा है कि right testis is not palpable in the scrotum or inguinal canal. मतलब we are not able to palpate. So ideally what should be done, beta? When we are not able to palpate the testis in an undescended testis baby, then first we can go for ultrasound. And if we are not able to localize that on ultrasound also, then the gold standard investigation, which is done in non-palpable testis, this is diagnostic laparoscopy. Right, beta? खेलना कैसे अपने को? अगर टेस्टिस को पाल्पेट नहीं कर पा रहे हैं, छोटा सा बच्चा है, तो पहले अल्ट्रासाउंड करेंगे. अल्ट्रासाउंड में भी अगर अपने को टेस्टिस नहीं दिखाई दे रही तो डायग्नोस्टिक लैप्रोस्कोपी. अगर देखा जाए कि गोल्ड स्टैंडर्ड क्या है, कई लोग अल्ट्रासाउंड भी स्किप कर देते हैं अगर टेस्टिस को पल्पेट नहीं कर पा रहे हैं, एंड दे डायरेक्टली गो फॉर डायग्नोस्टिक लैप्रोस्कोपी. एंड दिस इज अ रीसेंट एडिशन इन द न्यू बेली एंड लव कि बॉस gold standard investigation for localization of non-localization of testis in a baby where you cannot palpate the testis. That is diagnostic laparoscopy. So the correct answer for this, beta G, will be diagnostic laparoscopy. Okay. Amod, lovely good evening beta. Thank you so much. तो यहाँ पे ये ध्यान रखना बेटा, इसको ऐसे खेलेंगे. Undescended testis or cryptorchidism is a condition where one or both testes fail to descend into the scrotum, generally by 6 months. Nowadays, the recent guidelines say 3 months also. Most undescended testes descend spontaneously. If the story persists even after 6 months, then intervention is required. Like, if we are able to localize the testis, then we have to do orchidopexy. And beta, the ideal age for doing orchidopexy is 6 to 18 months. According to the latest guidelines, this is the ideal age for orchidopexy. If 6 to 18 months is not given in the option, then second best answer for orchidopexy will be 6 to 12 months. Right. Now, whatever options were given in this question, observation until 2 years, no. Observation is not recommended after 6 months because spontaneous descent is unlikely and delayed treatment may increase the risk of infertility and malignancy. Ultrasound, ultrasound is not the best diagnostic tool for non-palpable testes. Best or gold standard will be diagnostic laparoscopy because ultrasound has low sensitivity and specificity for locating the intra-abdominal testes. MRI is generally not used in infants. Diagnostic laparoscopy is the gold standard for evaluating the non-palpable testes. It helps to locate the intra-abdominal testes and allows for therapeutic interventions such as orchiopexy or orchidectomy in the same setting. Right, beta? So please be careful. As soon as you see the question, don't jump onto the answer straight on. Right? Thank you so much, Amod beta. Thank you so much. Right. I would just like to remind all the great doctors of India who are watching this session right now. सक्सेस की सबसे खास बात है कि वो मेहनत करने वालों पर फिदा हो जाती है. इसलिए बेटा मेहनत करते रहना है. जस्ट कीप ऑन डूइंग योर ग्रेट हार्ड वर्क. क्योंकि जो कड़ी मेहनत करते ना बेटा, एवरीबडी इज वॉचिंग देम. ऊपर वाला इज ऑल्सो वॉचिंग देम. And let me remind all of you, beta, that if you are doing sincere efforts, hard work, then they're not going to go in vain. God is definitely going to help us, and He'll definitely help in making you score big. Right. Now, let's move to another question, beta. डरना नहीं है अर्पित बेटा. डरना ठीक है, बस हिम्मत रखना है. चैलेंजेस आते हैं, बहुत सारे चैलेंजेस अर्पित बेटा. यू हैव फेस सो मेनी चैलेंजेस आउटसाइड इंडिया ऑल्सो, है ना. तो उससे भी फाइट किया ना बेटा अपन ने. तो लड़ना होता है. वी हैव टू कीप ऑन ग्राइंडिंग ऑन अ डेली बेसिस. रोज लड़ना है, हिम्मत नहीं हारना है. वी हैव टू हैव अ नाइस स्टडी प्लान कि बॉस, वंस आई वेक अप एंड स्टार्ट स्टडिंग, फर्स्ट 2 hours in the morning आई विल गिव टू द वीक एरियाज. Then I'll split my day into 5 hours and 5 hours session, giving my 5 hours for revising the important subject. You can do the same subject in 5, then 5, or you can use 2 subjects. First subject in first 5 hours, second subject in next 5 hours. And then before you go to bed, give 1 hour for solving the MCQs. And just go in a consistent manner. No new content at this point of time, beta. With my folded hands, request to all the lovely doctors, जैसे भी बेटा आपने तैयारी की है, whatever resource you have used, stick to that resource. No new content at this point of time, right? अगर अपन उतना ही याद कर लें बेटा जो हमने पिछले 3-4 महीनों में पढ़ा है, तो भी हम जीत जाएंगे, है ना? Right. Okay. Now, if you look at the art of solving questions, beta, all the lovely doctors who are watching this, they know this nicely कि when we are facing lengthy questions, then how we have to play the game. For image based questions, just reminding all of you beta, first you have to look at the image, then you have to look at the options, then you have to read the last line, and then you have to read the stem of the question. Okay, so if we look at the image here, okay, so here in this image beta, what we can see is there is a abrupt tapering here, right? So, okay. So already you have started answering beta D, B, and okay. Let's see. So this abrupt tapering, this would be a classical beta bird beak appearance, bird beak or pencil tip appearance, right? And then this thin rim of contrast which is flowing down, this would be a rat tail appearance type of story, but rat tail is more commonly seen in cancer of the esophagus. Okay, fine. Now, if I take a look at the options here, upper GI endoscopy, manometry, CT, and pH. Okay. Let me read the last line. What is the best next step in confirming the diagnosis of eclasia cardia? Okay, so he's asking what is the best next step in confirming the diagnosis. Okay, fine. Ideally, he has simply straight on said what is the best next step, but still, before we go with the right answer. Let us read the question. 45-year-old male presents with progressive dysphagia for solids liquids, regurgitation of undigested food, barium shown below, next best step. Okay, so this is a game where a 45-year-old patient presented with dysphagia story, right? And now, in this dysphagia story, just give me a moment, beta. Right. Okay, beta. I'm so sorry for the interruption. तो बेटा इसमें कैसे खेलना है अपने को? Herein, if we just try to understand this story, this is a clear-cut case of ecclesia cardia, right? Now, in ecclesia, how to approach the patient? First, we are doing a barium swallow, and then barium swallow is giving us this traffic jam type of situation, na beta? So, in this traffic jam type of situation, there can be various motility disorders which are causing this story. Now, to segregate these different motility disorders, as we know, there can be a case of nutcracker esophagus, there can be diffuse esophageal spasm, or anything. For example, if we take a look at these particular images here, beta, like because these are hot image based questions, especially in the upcoming exam. This is a rat tail or a pencil tip appearance. If I try to zoom it a little more, right? Now, this image, this is also a bird beak or pencil tip appearance. And this, what you are seeing, this is a corkscrew esophagus, beta, right? So I hope all of us can make out. This is the corkscrew esophagus. Now, the thing is, once barium swallow has been done, then to segregate the different motility disorders, we should do a manometry, right? And we know that the normal intraesophageal pressure is approximately 10 to 25 millimeter of mercury. But in ecclesia cardia, this pressure increases from 25 and it can go up to 100 millimeter of mercury. In nutcracker, 180 to 200, and in diffuse esophageal spasm, even more than 300 to 400 millimeter of mercury, right? So this becomes the standard investigation in ecclesia cardia. If we go into the detailed description that why this answer is correct and why this answer is not correct, beta, then we should know that ecclesia cardia is a motility disorder where there is failure of relaxation of the lower esophageal sphincter due to unopposed action of acetylcholine. There is unopposed action of the acetylcholine, right? That is why the lower esophageal sphincter remains contracted. Now, the classical symptoms are dysphagia, initially more for liquids and gradually for liquids as well as solids. There would be regurgitation, there would be halitosis also, and because of stasis of food in the esophagus, we can even find something like esophagitis, which is more often seen in the middle esophagus. However, if there is long-term stasis, then it can even lead to squamous cell carcinomas in the middle esophagus, right? Now, option A, endoscopy, is useful to rule out the structural lesions or malignancy. But in ecclesia, it is a game of functional disorder where the peristalsis is not there. Option C was CT. This may be done to rule out any external compression or malignancy, but it is not specific for ecclesia. And option D, beta, please do not confuse pH monitoring in ecclesia. pH monitoring is a game which is used in, किसमें use करते हैं बेटा pH monitoring को? Yes. Thank you, Zidan, beta. Rohit, yes. Standard investigation is manometry. Wonderful. To rule out cancer, we do endoscopy, Ajit. That's right. Mayur, very good. Liquids initially, yes. Om Prakash, very good. Very good. Yes, Sean. वेरी गुड. सो पी द गेम ऑफ पीएच इज फॉर जीआरडी. तो बेटा कई बार क्या होता है ना, बच्चों को यहाँ पे ये जो एरिया है ना, मैनोमेट्री और पीएच, ध्यान रखना है बेटा. मैनोमेट्री इज अ गेम इन एक्लेसिया, क्योंकि एक्लेसिया में क्या हो रहा है, ट्रैफिक जैम है, और ट्रैफिक जैम होगा तो प्रॉक्सिमल पीपल विल डायलेट एंड प्रेशर इन द प्रॉक्सिमल पीपल विल इंक्रीज, एंड इफ यू हैव टू मेजर द प्रेशर you will use manometry. But the game in GRD is reflux. And you know the pH inside the stomach is 1.5 to 2 or 2 to 3, which is strongly acidic, while pH inside the esophagus is 5 to 7, right? So what happens in GRD? This acid coming and burning the lower esophagus, presenting with heartburn. So there pH monitoring comes into play, right? तो इन दोनों को बेटा मिक्स नहीं करना. 12 जनवरी को ध्यान रखना, ओके? pH monitoring, GRD. Manometry, eclasia, right? Okay. So dysphagia is both for solids, liquids. Regurgitation, weight loss can be there. Barium swallow, bird beak. Manometry confirms the diagnosis. Management involves pneumatic dilatation, halasmyotomy, or POEM, that is peroral endoscopic myotomy. Right. Perfect. Okay. Now another question, beta. A 45-year-old. Oh, this looks to be a lengthy question. So let me just quickly remind all the lovely doctors of this country how to solve the lengthy questions. For the lengthy questions, beta, yes, what we are supposed to do? First we have to read the last line. Second, we have to look at the options. And third, we have to go with the stem of the question. Right. Absolutely correct, Phil. The less nitric oxide. That's absolutely correct. Very good. Let's see. So we read the last line of this question here. What is the next step in the management? Okay. Next step, right? Be careful, beta. He is asking about the next step. Okay. Endoscopy, contrast esophagography with water-soluble contrast, CT scan of the chest, and placement of nasogastric tube and observation. Okay. Endoscopy, barium, not barium, but water-soluble contrast, CT, and nasogastric tube. Okay, let's see what is the clinical scenario. Sorry. 45-year-old. Age is just a number, but not for the MCQs. 45. Okay. Emergency. Severe chest pain, vomiting. That started after heavy alcohol consumption. Oh, so heavy alcohol consumption, beta. 4 bottle vodka. Right. Okay. That means binge drinking. Okay. And all the lovely doctors, beta, you know the game of binge drinking, binge eating. 2 pathologies. Bohr-Havi syndrome, Mallory-Weiss-Steer. Both are associated with binge drinking, binge eating. एक बार में ज़्यादा खाना पीने से, when the intragastric pressure is high, then there may be forceful vomiting. And when the stomach contracts forcefully, then high pressure. And if this pressure is causing tear in the mucosa at the gastroesophageal junction, presenting as bleeding, उसको क्या बोलते हैं बेटा? अजीत? Yes, very good, Laryn Lakpam. Very good. You are absolutely correct. जब भी ज़्यादा खाना पीना खा लेते हैं, स्टमक में प्रेशर बढ़ता है, फोर्सफुल वॉमिटिंग होती है, और प्रेशर के साथ ये गेम ऊपर आती है. And if it is causing a tear in the mucosa at the G junction, presenting as bleeding, that is Mallory-Weiss. Lovely, Shivansh. Very good. Well done. Very good. Yes, Ajay, that's true. ठीक है ना बेटा? Or if forceful vomiting, that is causing rupture of the lower esophagus on the left side. So all the intragastric contents are released into the mediastinum under pressure. That is Bohr-Havi syndrome or barotrauma, and that presents with left-sided chest pain radiating to the left shoulder and the left arm, mimicking acute myocardial infarction. है ना बेटा? Right? Okay. Perfect. So ध्यान रखना बेटा ये game. This can be a hot MCQ for 12 January. Bohr-Havi syndrome, Mallory-Weiss-Steer. The game is binge drinking, binge eating. If it is mucosal tear, G junction hematomasis, Mallory Weiss tear. If it is lower esophageal rupture, left-sided chest pain, then it is Bohr-Harvey syndrome. But in a patient who is chronic alcoholic, chronic liver disease, portal hypertension, and hematomasis story, then this is going in favor of esophageal varices, right? तो यहाँ पे ये ध्यान रखना है. Okay, let's go to the question. 45-year-old emergency chest pain, vomiting, heavy alcohol consumption, right? Febrile, tachycardic, and subcutaneous emphysema over the neck and the upper chest. Chest X-ray shows mediastinal widening. That means huge amount of air would have collected in the mediastinum. Pneumomediastinum हो गया बेटा, है ना? And pleural effusion is also seen on the left side. So this game is clear-cut a game of Bohr-Harvey syndrome. How to play this game? Now we can do a chest X-ray, which has already been done, which is showing mediastinal widening. If we want to know the exact site and size of rupture of the perforation, then we can do a contrast swallow. But don't use barium, because barium is hypertonic. If it leaks out of the perforation, it can create injury to the surrounding structures. So we prefer using water-soluble contrast. Yes, Ajit, very good. Like iohexol, right? Fine. And we can even do a CT scan where we can use this oral water-soluble contrast as well, right? Okay. But to know the exact site and size of rupture, we prefer doing a water-soluble contrast study, either with a CT or with just a X-ray, right? That is a contrast esophagography. So that will give us the exact size of the perforation. Let us see the different options here. The endoscopy will not be the right answer. So here the right answer will be contrast esophagography, right? And let us see beta why this answer is correct and why this answer is not correct. So if we look at the explanation part, Bohr-Harvey syndrome is a spontaneous esophageal rupture typically resulting from forceful vomiting. It is life-threatening, require prompt diagnosis and management. Key points for understanding this question beta. एक तो clinical presentation पे game है इसमें. Sudden onset of severe chest pain after vomiting, subcutaneous emphysema and mediastinal signs such as widening. Diagnostic approach के लिए contrast esophagography, water soluble contrast like iohexol gastrographin is the diagnostic modality of choice. Why not other options? Why not endoscopy beta? Because endoscopy is risky in suspected esophageal perforation due to potential worsening of the injury. Why not CT beta? CT is useful for evaluating complications like mediastinitis but does not directly confirm the perforation. That contrast which is going inside, when it leaks out from the perforation, that will give us the best diagnosis for the site and size of perforation. And placement of nasogastric tube and observation beta, this is not something which we are going to use in Bohr-Harvey. This will be using in iatrogenic esophageal perforations, right? Neha, that's right. Yeah, CT with gastrographin would have been the perfect answer. That's right. Delaying putting a nasogastric tube and observation, this will delay the diagnosis and treatment in Bohr-Harvey and can lead to fatal outcomes. The treatment in Bohr-Harvey, because there would be huge amount of mediastinitis, septicemia type of story, and all the great doctors who are watching this session, they know nicely that whenever there is huge amount of contamination, for example, if there is spreaded contamination like mediastinitis or peritonitis, then to save the life of the patient, we have to do lavage. Lovely, good evening, Devangan. Right. Ajay, that's right. That is transmural. So we have to do the lavage to save the life of this patient. So early diagnosis followed by surgical repair or endoscopic stenting can be done. We have to use IV fluids, antibiotics, and we have to manage the sepsis story. Right. Yes. Let's take a look at another question, beta. Suppose this looks to be a lengthy question again. So let's follow the art of solving the questions. For lengthy questions, we have to read the last line, then the options, and then the stem. So here, what is the last line? Last line is what is the most likely diagnosis? Okay. Now, what are the options here? Acute cholecystitis, choledocholithiasis, acute cholangitis, and gallstone pancreatitis. Okay. So, one game he is asking about the gallbladder story. This is a acute story he is focusing on. This is just a CBD stone, not a acute story. This is a CBD party he's talking about, acute CBD party. And this is maybe acute pancreatitis. Okay. Now, beta ji, how to play this game? You have got these four options. You know, if the game would be related to gallbladder, then gallbladder game would be in this area, right hypochondrial area. If the game is related to choledocholithiasis, he is not saying cholangitis in this option. He's just saying choledocholithiasis. Chole means bile, doco means duct, litho means stone. तो सीबीडी में सिर्फ पत्थर की बात कर रहा है, कोई पार्टी वार्टी की बात नहीं कर रहा है यहाँ पे. ओके, सो दिस इज जस्ट अ स्टोन इन द सीबीडी स्टोरी. Then cholangitis. Now here in cholangitis he is talking about a party in the CBD. Okay, so CBD party he is talking about. And pancreatitis story. Pancreatitis story would be a party in the pancreas somewhere here, right? So now let us try to figure out which out of these four will fit the best, right? 45-year-old lady, right upper quadrant pain. Okay, so this may be gallbladder story or maybe a cholangitis story. There is fever. Fever can be seen in cholecystitis, acute cholecystitis, as well as cholangitis, as well as acute pancreatitis. But my dear lovely doctors, acute pancreatitis, fever is not an early feature, because acute pancreatitis, it is not the bacterial party initially, it is the enzymatic party. Right, beta? Enzymes are causing digestion of the pancreas initially. That is why there is no role of prophylactic antibiotics in acute pancreatitis, right? Okay, so here he is saying pain in the right upper quadrant. That means it can be a game of gallbladder, it can be a game of CBD, right? Fever, again it can be a game of gallbladder, CBD. Jaundice. Oh, so now tell me, beta, see, now this word is going to be important for us. Jaundice game. Jaundice game will be seen in gallbladder or it will be seen in CBD. So we are seeing A option and C option, right? Okay. Let's see. Jaundice. Pain, fever, jaundice, Ajit. Yes. What is that? Charcot's triad. Great. Alcoholic history for acute pancreatitis. Priya is saying acute cholecystitis. Okay. Nayan is saying Charcot's. Yashwant lipase. Okay. So still going on with ABC and CBD. Okay. Let us go further. On examination, beta, she has tenderness in the right upper quadrant and a positive Murphy sign. Oh my God. So he's saying positive Murphy sign, positive Murphy's when the gallbladder is red hot. Okay, so this can be a case of gallbladder also. But if it is acute cholecystitis, then why the patient is having jaundice? जॉन्डिस तो तब होगा बेटा जब सीबीडी में ट्रैफिक जैम लगेगा. अगर सिर्फ गॉल ब्लैडर गुस्से से ला ले तो जॉन्डिस नहीं होना चाहिए. कोई बात नहीं, देखते. ब्लड इन्वेस्टिगेशंस रिवील ल्यूकोसाइटोसिस. दैट कैन हैपन इन एनी एक्यूट कंडीशन. Elevated liver enzymes, SGOT, SGPT and all, they are elevated, okay? And direct hyperbilirubinemia. So patient is having jaundice, direct hyperbilirubinemia, that means obstructive jaundice type of story. Ultrasound shows gallstones. So this should be a case of acute cholecystitis, but only jaundice is something which is against this, right? And bile duct is dilated. Oh, so bile duct is also dilated. Now there is a possibility, beta, that there was a stone in the gallbladder which has slipped into the common bile duct, and this is causing traffic jam in the common bile duct. अगर common bile duct में traffic jam लग रहा है तो proximal people are getting dilated. So this can be a case of choledocholithiasis as well. And because of traffic jam in the bile duct and proximal dilatation, stasis of bile in the CBD, invitation for the bacterial party in the CBD, cholangitis, and cholangitis is presenting with pain, fever, jaundice. Okay. Right. So, beta ji, what a wonderful question this is. See, he has confused you with positive Murphy's. He is giving you right upper quadrant pain and fever. Now, this right upper quadrant pain, fever, positive Murphy's, leukocytosis, this can be seen in acute cholecystitis. The game is not choledocholithiasis because there is no party in simple choledocholithiasis. If you already have acute cholangitis in the option. Now, if you see acute cholangitis, beta, in acute cholangitis, you can find pain in the right upper quadrant. You can find fever. You can find jaundice, that is Charcot striate pain, fever, jaundice. You can get this positive Murphy's also, though it is more often seen more specific for acute cholecystitis. But if there is traffic jam in the CBD, proximal people getting dilated, proximal CBD and gallbladder getting dilated, stasis, party, this would be causing red hot gallbladder also. That is giving us a positive Murphy's sign. Now, leukocytosis can be seen in everything. But elevated liver enzymes and direct hyperbilirubinemia, this is going more in favor of CBD obstruction. Ultrasound is showing gallstones. This is going in favor of cholecystitis. But bile duct dilatation is going in favor of cholangitis. So if we compare acute cholecystitis from cholangitis, beta, in acute cholecystitis, we are not able to understand why the patient is having jaundice, why the patient is having dilated CBD on ultrasound. But in acute cholangitis, yes, we can explain everything. Pain, fever, jaundice. We can explain a positive Murphy's sign as well. We can explain the leukocytosis. We can explain the elevated liver enzymes and direct hyperbilirubinemia. So in such type of questions, beta G, when you have to segregate, then herein acute cholangitis becomes the better choice out of all the given options. That is why the correct answer for this beta, this will be acute cholangitis. This is the most appropriate answer, right? And as we know, in our exams, we are asked to choose the most appropriate answer, right? Okay, let's take a look. Yes. If we look at the explanation and the key takeaways in this, we know that the classical clinical presentation is that pain, fever, jaundice with all this what we have discussed. Why not the other options, beta? Why not acute cholecystitis? As you can see, it presents with right upper quadrant pain and positive Murphy's, but does not typically cause jaundice unless there is concurrent biliary obstruction. Look at me on the screen, beta. This is going to be crucial. I want all the great doctors of this country. You are the future of this country. You are future India. तो एक एक चीज को अपने दिमाग में तार तार करके सेग्रीगेट करके रखना है. We have to segregate each and everything. कि boss, if it is the game of gallbladder, then it is the game in the right hypochondrium, right? And we are not talking about CBD story if we are focusing on gallbladder story. But if we are targeting the CBD story, if we are saying CBD obstruction leading to party in the CBD, then there is proximal dilatation, which is not only causing proximal CBD dilatation, but it is also causing distended gallbladder, and there would be biliary stasis not only in the CBD, but even in the gallbladder, and this stasis will be an invitation for the party. So if it is a CBD obstruction causing proximal party, it can be cholangitis as well as acute cholecystitis. इन चीजों को तार तार करके सेपरेट करके रखिएगा बिट्टा जी, right? Okay, so no bile duct dilatation is seen in isolated acute cholecystitis. Another important story, beta, choledocholithiasis, it simply refers to the presence of stones in the bile duct and may cause similar symptoms. But my dear lovely doctors, fever and systemic inflammation are less prominent without associated cholangitis. And gallstone pancreatitis, generally this game will be where there would be epigastric pain radiating to the back with elevated amylase lipase. I saw in the live chat option, beta, It was not amylase lipase in the question, it was liver enzymes in the question. तो ध्यान रखना बेटा, कई बार जल्दबाजी में हम इसको लाइपेज एमाइलेज ना पड़ जाए, है ना? ओके, वंडरफुल, लवली क्वेश्चन. ओके, elevated amylase lipase and often without jaundice unless biliary obstruction is there. So the key takeaway for this question: acute cholangitis is a medical emergency requiring prompt treatment, typically involving antibiotics and biliary drainage, maybe ERCP and stenting. And recognition of Charcot stride is crucial for early diagnosis and management, at least in our exams. Right, beta. So now let's move to another question. Yes, everyone. Sunshine. अच्छा था ना बेटा? Yes, Nayan. Right. Thank you so much, Mubashir. May God bless you always. Vinay, how to differentiate between inlay, sublay, onlay? देखो बेटा, it depends on where you are placing the mesh. I am just answering for Vinay this question. When you are keeping a mesh above the anterior rectus sheath, that is onlay. When you are keeping it above the posterior rectus sheath, that is sublay. When you are keeping it below the peritoneum, intraperitoneal, that is underlay. And if you are using a mesh to close the defect, that means you are putting the mesh to close the defect, that is inlay, right? Okay. Lovely. Oh, so you have even answered, Shivansh. Lovely. So fast. कोई नहीं रोक सकता बेटा आपको इस एग्जाम को क्रैक करने से. हिम्मत नहीं हारना, ऐसे ही फोड़ते रहना है. देखो अभी क्वेश्चन पढ़ा भी नहीं है एंड ऑल ऑफ यू हैव कम अप विद द आंसर. लेट मी रीड द क्वेश्चन. सपोज दिस इज ऑल्सो अ लेंथी क्वेश्चन बेटा. So we'll follow the same art of solving the questions. We'll read the last line of the question first, and then we'll look at the options, and then we'll read the stem. Right. So here, most reliable diagnostic imaging modality for confirming acute pancreatitis and assessing the severity. Oh. So it is basically, you can say, whatever is written here, that may or may not matter because he has given everything in the last line. Most reliable diagnostic imaging modality for confirming acute pancreatitis and assessing the severity. All of you have perfectly rightly answered this question. All of you have said B. You are absolutely right. So that means there is hardly anything to be discussed. But yes, X-ray, CT, MRI, ultrasound. These are the simple options. Let us take a look if there is anything to be discussed in the question. 45-year-old presents to emergency, severe epigastric pain radiating to back, nausea, vomiting for past 12 hours, chronic alcoholic, tenderness in the epigastrium, raised amylase lipase levels more than 3 times normal. Just a clear-cut description of acute pancreatitis story, right? And he's asking what is the investigation of choice. Let us take a look at these important points. Why X-ray? Why not X-ray? Because X-ray has limited utility. It may show indirect signs such as sentinel loop or colon cutoff, but it cannot confirm the diagnosis of acute pancreatitis. Ultrasound is a good initial tool to detect gallstones or biliary pathology, but it is less reliable for assessing the pancreas in acute inflammation due to bowel gas interference. MRI can be used for detailed imaging, particularly in cases of suspected pancreatic necrosis or when CECT is contraindicated like in renal failure. CECT is the imaging modality of choice for confirming acute pancreatitis and assessing its severity, including complications like necrosis, abscess, or pseudocyst. And beta G, it is typically performed 48 to 72 hours after onset to allow better delineation of the extent of pancreatic inflammation and necrosis. That is why CECT is the most reliable imaging tool for diagnosis and severity assessment. Right? Okay, so what is the correct answer for this? Correct answer will be CECT. Right. Yeah, chronic alcohol use, Neha. It can be chronic pancreatitis, but you will not find raised amylase lipase levels in chronic pancreatitis to this extent. And patient is presenting with anorexia, nausea, vomiting, and epigastric pain radiating to the back. So, Neha, alcohol is also an important cause for acute pancreatitis, right? So it may be a case of chronic inflammation, but patient is presenting in emergency with acute episode. So currently what we are talking about is maybe a case of acute on chronic pancreatitis, right? Thank you, Paras Beta. Thank you so much. Lovely. Okay, just give me a moment. You solve this question and let's see. Yes, Beta ji. Okay, so we are receiving the answers C, then D, B. Okay, Monishkar is saying PCNL. So we are going on in B, C, D. Okay, majority going with okay. B and C, B and C is going on. Okay. A has also come up. Now D has disappeared. Okay. So B and C, B and C is going on. Okay. Right. Let's take a look at it. 45-year-old male present with sudden severe flank pain radiating to the groin. Okay. Flank pain which is going towards the groin. There is hematuria and nausea. Non-contrast CT reveals 4 millimeter calculus in the distal ureter. Okay. So there is 4 millimeter calculus in the distal ureter. Okay, ji. Suppose this is the game here. Right. Now the question is 4 millimeter stone in the lower ureter. Fine. What is the most appropriate initial management for this patient? Okay. Initial management. Fine. Whether we should do a immediate ureteroscopy or we should do ESWL or we should do conservative management or we should go with PCNL. Right. So these are the options. Now, beta ji, let us first and foremost, let us just try to see what is we have understood in the sessions. We know that diameter of ureter and diameter of urethra. This is approximately beta kitna hota hai? 6 to 8 millimeter, right? So any stone which is up to 5 millimeter or maybe less than 5 millimeter in size that can pass spontaneously. अगर बेटा छोटा सा पत्थर है 5 मिलीमीटर से छोटा तो ये तो अपने आप इस रास्ते से निकल जाएगा, है ना? क्योंकि diameter of ureter and urethra is 6 to 8 millimeter. So any stone which is less than 5 millimeter or up to 5 millimeter can pass spontaneously, na beta? You remember, we just have to encourage the patient to take plenty of fluids. फिर patient may ask you, Doctor साहब, can I take beer? And then we say, we cannot prescribe beer. But if patient is asking, then we can advise him, okay, if you want, you can take 2 chilled beers, right? So stones which are less than 6 millimeter or 5 millimeter in size, they can pass spontaneously. Nothing has to be done. This is one game. Another game, beta. Now suppose we are talking about stones which are 5 or more than 5 millimeter in size. If the stone is in the kidney, upper ureter or middle ureter, then we use Baba waves, ESWL. So those shock waves will break the stone into small fragments and these small fragments will pass spontaneously in urine. If it is in the lower ureter, 5 or more than 5 millimeter in size, then we can simply pass a ureteroscope and a Dormia basket and retrieve this with the help of Dormia basket, ureteroscopic retrieval of stone. If the stone is inside the bladder bitta, we can pass a cystoscope in the bladder and we can break the bladder stone into small fragments, and these small fragments will pass spontaneously in urine. And if the stone is in the urethra beta, then we have to push the urethral stone with the help of cystoscope into the bladder and treat it like a bladder stone, right? तो bladder stone के लिए लिथोलापेक्सी बोल देते हैं अपन उसको. However, when we cannot use the ESWL for kidney or upper ureteric stone, then we do PCNL, right? So this is how. Yes, Shivansh. है ना बिट्टा? तो अब इफ यू ट्राई टू सी द समरी हियर, तो लेस देन 5 मिलीमीटर के लिए प्लेंटी ऑफ फ्लूइड्स, 5 और मोर देन 5 के लिए ESWL, किडनी अपर मिडिल यूरेटर के लिए, लोअर यूरेटर URS, ब्लैडर के लिए लिथोलापेक्सी, एंड यूरेथ्रा के लिए यू हैव टू पुश द स्टोन इनटू द ब्लैडर एंड ट्रीट लाइक अ ब्लैडर स्टोन. नाउ ESWL, we can break the stone into small fragments. Like here we can see the patient is asked to lie on this special table. Shock waves are fired directly onto the stone. Stone is broken into small fragments, and these small fragments align themselves in the ureter street of stones, Steenstra's phenomena, right? Okay, and they'll pass spontaneously in urine. But we should not use ESWL if the stone is more than 2 centimeter in size. अगर बड़े पत्थर को तोड़ेंगे बेटा तो उसका फ्रेगमेंट भी बड़ा हो सकता है. अगर 5 मिलीमीटर से बड़ा हुआ तो ये रास्ते में फंस जाएगा. If the fragment of stone is more than 5 millimeter, it may get stuck in the ureter. So we should avoid ESWL for bigger stones more than 2 centimeter. Pregnant ladies, we can't use ESWL. Bleeding disorder patients, any distal obstruction or cystine stones, which are the hardest stones, they are difficult to be broken by shock waves. So in those cases, we prefer doing a PCNL. और PCNL में कैसे खेलना होता था बेटा? We are making a small cut posteriorly, and then we are creating a tract from the skin up to the pelvic axial system and break these stones. Any bigger fragment, it can be retrieved with the help of Dormia basket. है ना? Okay. Right. So this is the Dormia basket what we are using. ऐसे एक बास्केट ले जाके और फिर वी कैन रिमूव द स्टोन्स. और बेटा अगर कंप्लीट ट्रैफिक जैम होता था यूरेटर में तो वी वर पासिंग अ डबल J स्टेंट, है ना, फॉर कंप्लीट यूरेट्रिक ऑब्स्ट्रक्शन. डबल J स्टेंट, राइट. Okay. So the detailed explanation is given here, beta, that this is the classical clinical presentation of ureteric stone, ureteric colic. CT findings are specifically saying that 4 millimeter stone in the lower ureter. What we should do? We should do conservative management for stones up to 5 millimeter in size. We can give alpha blockers, beta, which can relax the smooth muscle. The URS, ESWL, PCNL we have already discussed. So if we look at this particular question बेटा, इसमें जो गेम जिसने बदली बेटा, एक तो साइज ऑफ द स्टोन 4 मिलीमीटर कैलकुलस और डिस्टल यूरेटर में है, तो अप्रोप्रिएट इनिशियल मैनेजमेंट शुड बी कंजर्वेटिव मैनेजमेंट, है ना, कंजर्वेटिव मैनेजमेंट विद एनाल्जेसिक्स एंड अल्फा ब्लॉकर्स. Right. Yes, Amir, we can do retrograde intrarenal surgery as well. Yes, double J Priya. That's perfect. Very good, Siddharth. Yes, beta. PDF. I'll be putting this PDF as well in this YouTube link only. Okay. Right. Now this again looks to be a little lengthy question, beta. Here, if we focus, which of the following is the most appropriate next step in the management for this patient? Okay. Options are CECT, ultrasound, appendicectomy, analgesics, and OPD follow-up. Okay. Right. So let me wait for the answers, beta. Alpha blockers, Shantanu beta, they will relax the smooth muscle ना, तो that stone can pass. अगर यूरेटर की muscles relax हो गई ना बेटा, तो वो stone अटकेगा नहीं, निकल जाएगा. Stone will not get stuck, it will pass. Marwan Omani beta, more than 2 centimeters. Right. So majority are answering C, few are answering D, and some options I am seeing is B. Okay. Let me read this B, C, D, ultrasound, appendicectomy, analgesics. Okay. Let me see what majority are answering. Yashwant, wonderful. Clinical diagnosis enough for appendicitis. Uh-huh. Manohar is answering CT. Okay. Priyanjana Argent, Osherman Lalit. Okay. Oshner Sharon. Okay, Lalit, that is for appendicular mass. Venkat is answering B. Okay, let us read this. Fine. So, most appropriate next management is what he's trying to ask. Most appropriate next step. Okay, whether to go for CT, ultrasound, operation, or analgesics. Right, fine. 28-year-old male presents to emergency, 24-hour history of abdominal pain. Initially, pain was diffuse around the umbilicus, but now has shifted to the right lower quadrant. Oh, so this is the classical game of acute appendicitis. Periumbilical pain shifting to right iliac fossa. Loss of appetite, nausea, fever. Okay. Tenderness at the McBurney's point. Wonderful. So, giving acute appendicitis, there is rebound tenderness, and even there is positive Ropsing sign. So, it's a clear cut game of acute appendicitis, beta. We are finding McBurney sign, Ropsing sign, along with rebound tenderness, right? So, if we look at the mentrels, मेंट्रल स्कोरिंग क्या होता था बेटा? मेंट्रल्स और एल्वेरेडो स्कोर क्या था बेटा? एम फॉर माइग्रेटरी राइट iliac fossa पेन, एनोरेक्सिया, nausea, vomiting, tenderness, rebound tenderness, elevated temperature, leukocytosis and shift for neutrophils. इसमें everything was given 1 point except tenderness and leukocytosis. They were given 2 points. So total score is 10. If the score is 5 or more than 5, if the score is 5 or less than 5, then acute appendicitis is ruled out. But 7 or more than 7, very high probability of acute appendicitis. Okay. So lab investigations reveal leukocytosis and neutrophils. Okay. So 2 plus 1, 3, 4, 5, 6. Right. Along with 7, 8. Okay. Fine. So it's a clear-cut case of acute appendicitis. Now, most appropriate next step. When it is a clear-cut case of acute appendicitis, generally no investigations are required. It's a clinical diagnosis. Only if the patient is fussy. Suppose you are taking the patient for appendicectomy and patient is fussy. No, doctor, please show me how it is appendicitis. I cannot rely on your clinical diagnosis. In those cases, we go for CCT. Otherwise, we can straight on take this patient for operation. In mild appendicitis, we can give antibiotics, but this looks to be a clear-cut case of severe appendicitis. So we have to go for operative emergency appendicectomy. And remember, my dear doctors, ultrasound is not done to diagnose acute appendicitis. It is done इन डायग्नोस्टिक कन्फ्यूजनल सिचुएशंस. जब अपन क्लियर कट डायग्नोसिस नहीं बना पा रहे ना बेटा, तब अपने को अल्ट्रासाउंड की मदद लेनी चाहिए. For example, a 25-year-old girl comes in the emergency with right iliac fossa pain. You are able to find tenderness, but rebound tenderness is missing. The girl does not remember when she had her last periods. So in those diagnostic confusional situations, like if you are thinking about ruptured ectopic pregnancy also, then you can take the help of ultrasound. And on ultrasound, if you find a blind ending tubular aperistaltic non-compressible structure with a diameter of more than 6 millimeter in the right iliac fossa, then it favors acute appendicitis. But here, because it's a clear-cut case, so no ultrasound is needed in this case. Ideally, it's a clear-cut acute appendicitis. If it would have been mild, we would have gone with antibiotics, but it is severe, so we are going with appendicectomy. So out of the given options, beta, all the lovely doctors, Shakir, Kamal, Sandeep, yes, USG for ruling out differential diagnosis. Wonderfully done, beta. So here the most appropriate answer would be perform urgent appendectomy, right? Okay. Yes, Indrajit. Patient has come to us in emergency. And this is the detailed explanation, beta. The patient exhibit classic clinical features of acute appendicitis, including migratory pain, anorexia, nausea, vomiting, McBurney's, rebound, positive Rovsing's, everything, neutrophils, leukocytosis. In such a clear clinical scenario, the most appropriate management is prompt surgical intervention to perform appendectomy. Delaying surgery could lead to complications like perforation, abscess, or peritonitis, which can significantly increase the morbidity beta. Imaging studies like ultrasound CT can be helpful in ambiguous cases. The strong clinical presentation in this patient negates the need for further diagnostic imaging. Starting antibiotics alone or opting for conservative management without surgery is not advisable given the high likelihood of acute appendicitis. Therefore, urgent surgical removal of appendix is the best course of action. Yes, beta. Yashwant, the low grade fever is there in the mental score. Elevated temperature है ना बेटा mentrals में E से जो है elevated temperature Yashwant, that is there. Yeah. And in acute appendicitis, generally the fever is less than 100.4 degree Fahrenheit. And beta, because you are going through tough times at this moment, so I would just like to remind the legendary great Sri Ratan Tata ji's few important lines. Ups and downs in life are very important to keep us going, because a straight line, even in an ECG, means we are not alive. So beta, we will be going through ups and downs. किसी दिन बहुत इलेशन होगा कि हाँ आज मैंने फोड़ दिया है, आई हैव डन इट, आज मेरे को इतना करना था, आई हैव डन इवन मोर देन दिस. एंड देयर वुड बी डेज व्हेन यू माइट बी फीलिंग लो बेटा कि आई वाज सपोज टू डू दिस मच बट आई एम नॉट एबल टू कंप्लीट दिस, आई एम नॉट एबल टू रिमेंबर. ये सारी जो गेम है ना बेटा, ये सारी यहाँ की गेम है. तो यहाँ पे जो थॉट्स आने हैं ना बेटा, इनकी प्योरिटी इज वेरी इंपॉर्टेंट. कीप द थॉट्स एज प्योर एज पॉसिबल. देखो बेटा, रिजल्ट्स विल नेवर बी इन आवर हैंड्स. रिजल्ट देने वाला है वो. बट हम क्या कर सकते हैं? हम अपना प्रयास कर सकते हैं बेटा, अपनी मेहनत कर सकते हैं. तो वी हैव टू जस्ट फोकस ऑन द प्रोसेस, फोकस ऑन द हार्ड वर्क. प्लीज ट्राई नॉट टू थिंक अबाउट द रिजल्ट्स. रिजल्ट का नहीं सोचेंगे, बस ऊपर वाले से यही दुआ मांगेंगे कि हे ईश्वर, इतनी हिम्मत देना कि जो ये आने वाला एक महीना है, इसको मैं पूरी मेहनत से, पूरी लगन से, जो मेरे सामने ये सिलेबस है, इसका जितना मैक्सिमम कंटेंट मैं इसको याद कर पाऊँ और थोड़े क्वेश्चंस की प्रैक्टिस कर पाऊँ, जिससे मुझे ये आइडिया हो कि मुझे जो चीज़ें मैं पढ़ रहा हूँ उसको किस तरह से अप्लाई करना है. बस दिस इज़ वॉट वी आर सपोज टू डू. ठीक है ना बेटा? एंड गॉड इज ग्रेट. लवली लवली ब्रीथ बेटा, है ना? तो ही विल डेफिनेटली हेल्प ऑल ऑफ अस. एंड आई फ्रॉम ऑल ऑफ अस अ बिग होमेज टू श्री रतन टाटा जी, जिन्होंने हमारे देश को देखिए बेटा कहाँ से कहाँ तक पहुँचाया. नमक से एरोप्लेन तक कहाँ इनका नाम नहीं था. और आई रियली विश एंड प्रे कि दिस FMG एग्ज़ाम तो एक छोटा सा हिस्सा है आपकी ज़िंदगी का बेटा. आफ्टर क्रैकिंग दिस FMG एग्ज़ाम विद अ बिग स्कोर, you will definitely be doing some great things in your life which will take our country even to better heights than what we are, where we are today. Right? तो बस अपने अंदर विश्वास ज़रूर रखिएगा, हिम्मत नहीं हारना है बेटा, लड़ना है अपने को हर रोज़ और हम जीत के रहेंगे. Right. So another question here. Which of the following is the most appropriate initial management for this patient? Okay. So he's focusing on initial management. Let us see what are the options here. Suprapubic cystostomy. Okay. Endoscopic realignment. Delayed urethral anastomosis after 3 months. And primary end-to-end anastomosis. Okay. 35-year-old male presents to emergency perineal trauma. देखो बेटा गेम यहाँ पे आ रही है. Perineal trauma है due to a motor vehicle accident. difficulty urinating. Okay, that means he's not able to pass urine. Suprapubic dullness है, blood at the meatus है. So this is a clear cut case of urethral trauma. और urethral trauma में पेरिनियल trauma में बेटा कौन सी urethral injury हुई? अफजल बेटा, if it is perineal, तो perineal means perineal urethra या bulbar urethra, that is anterior urethra, है ना बेटा? Okay. So this is the anterior bulbar urethral injury. Oh, he has written also. This is anterior urethral injury. Fine. Now कैसे खेलना है? अब यहाँ पे बेटा वो क्या कह रहा है? Suprapubic dullness बोल रहा है. Suprapubic dullness है. If suprapubic dullness is there, that means, see, patient is not able to pass urine. Suprapubic dullness is there, that means the bladder is full. है ना? So there might be retention of urine. Now what we know is, if we try putting a Foley's urethral catheter and if we find any resistance, do not force. No means no. Better to do a suprapubic cystostomy. है ना? So this will give the immediate relief to the patient. Now whatever injury is there in the urethra na, that injury is going to heal by fibrosis, and then later on we'll assess if there is a stricture, and suppose it is a chota sa stricture, then to we can treat it endoscopically. But if it is a bada stricture, say more than 2 centimeter in length, then we have to do a resection anastomosis type of thing, right? Okay. So he is asking most appropriate initial management for this patient. If the patient is having suprapubic dullness, that means there is retention of urine. So one word answer for urethral injury with retention of urine, suprapubic cystostomy. है ना बेटा? Right. Endoscopic realignment, no. Delayed urethral anastomosis after 3 months, that's right. If the length of the stricture is more than 2 centimeter, then we'll be doing a delayed urethral reconstruction. Right. Not a primary end-to-end anastomosis, not now. Right. So these are the explanations given, beta, and the key points are also mentioned here. Right. Now, 70-year-old, or let us go again with the last line, initial management should be considered in this patient. Options are TURP, 5-alpha reductase inhibitors, green light laser, and selective alpha 1A blockers. Okay. Right. So let me wait for all of you, beta. Okay. Shweta is saying B, Sean is saying D, Bhargav is saying TURP, Indrajit is saying Prazosin. Majority of you are saying B. Okay. B, 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 D. Okay. Tamsulosin, okay. So B, B, D, okay. Okay. So let's read the question, beta. Initial management he's asking from us. Now, in the initial management, let us see. 70-year-old male presents to urology clinic. That means in the OPD. Progressive lower urinary tract symptoms over the past year, including increased frequency, nocturia, weak urinary stream, sensation of incomplete bladder emptying, digital examination reveals enlarged smooth prostate, PSA level within normal limits, uroflowmetry shows reduced peak flow rate. Okay, so this is a clear-cut game of benign prostatic hyperplasia, and if we look at the different options, 5-alpha reductase inhibitors, selective alpha 1A blockers, these are used in the medical treatment. 5-alpha reductase inhibitors are finasteride, dutasteride, which help in reducing the size of the prostate, right? While selective alpha 1A blockers, they relax the prostatic urethra and improve the urine flow, like tamsulosin and elfusocin, right? So as you were saying, uh, tamsulosin, confuse B and D Atul, right? So here the game is the most troublesome symptom in BPH is poor flow, and we doctors, if we have to choose which medicine will give the maximum benefit to the patient, सब अपने को खेलना क्या है बेटा, अपने को पेशेंट की समस्या सॉल्व करनी है, और पेशेंट सबसे ज़्यादा परेशान किससे है, उसकी धार पतली हो गई है और बिल्कुल पैरों के पास गिर रही है. Patient is troubled because of his poor flow. The urine stream has become quite narrow in caliber and it is falling almost onto his legs. So if we have to choose between 5-alpha reductase inhibitors and selective alpha 1A blockers, selective alpha 1A blockers like tamsulosin will widen the prostatic urethra and improve the urine flow. So they are preferred medical treatment of choice, right? Now, whether to give medicines in this patient or should we go for surgery? So the game here is, if patient is having only mild symptoms of BPH, then we prefer giving medicines. But if patient is having severe symptoms, or beta G, there are complications of BPH like retention of urine, bilateral hydronephrosis, recurrent UTI, stones, diverticulas and all, तब बेटा we'll not wait for medicines, क्योंकि medicines will take long time to act, and if patient already has complications, तो अपने को we have to give immediate improvement. Then the treatment of choice will be surgery, and the surgical treatment of choice or gold standard surgery done for BPH patient is TURP, right? So the newer techniques have also come up like green light laser, uh, enucleation of prostate, holmium laser evaporation of prostate, they are also being used, but the gold standard is TURP. Now, the answer to this particular question can be either selective alpha 1A blockers or TURP. ठीक है बेटा, ये बैकग्राउंड से इतनी तो गेम अपने को समझ में आ गई कि या तो बेटा अपने को ये अल्फा 1A ब्लॉकर्स टेम्सुलोसिन देना है या अपने को TURP करना है. अब दोनों में से भी क्या चूज करना है ये डिपेंड करेगा क्या पेशेंट को कोई कॉम्प्लिकेशन है, इज द पेशेंट इज हैविंग एनी कॉम्प्लिकेशंस. अगर बेटा पेशेंट इज नॉट हैविंग रिकरेंट यूटीआई, इफ पेशेंट इज नॉट हैविंग बायलेटरल हाइड्रोनेफ्रोसिस और रिटेंशन ऑफ यूरिन और मे बी सीवियर ब्लीडिंग और मे बी डायवर्टिकुलर स्टोन्स, देन वी कैन स्टिल गो अहेड विथ मेडिसिन्स, राइट बेटा. अब देखो बेटा, यस नेहा, वी कैन यूज दैट केटीपीए लेजर एज वेल. तो इसमें लेट अस सी, urinary frequency, nocturia, weak stream, incomplete bladder emptying, enlarged prostate, PSA normal, uroflowmetry, reduced peak flow rate. But there is no evidence of any complications. Whatever symptoms he has given, he has mentioned about lower urinary tract symptoms. Storage symptoms, most common is frequency, nocturia, urgency, urgent continence. Voiding symptoms, hesitancy, poor flow, dribbling, retention. Right? Okay. So retention is also not there in this. So these are mild symptoms. We'll go with medicines. Now this is what. So the correct answer will be selective alpha 1A blockers. ठीक है बेटा? Right. Absolutely correct, Shakib beta. If patient symptoms are not controlled with medicine, then we are going for surgery. And beta ji, this is what is written in your missed surgery workbook. If patient is having only mild symptoms, no complications, medical treatment, and medical treatment of choice are selective alpha 1A blockers like tamsulosin. If patient has got better severe symptoms, complications, which include hemorrhage, retention, hydronephrosis, UTI, stones, diverticula, then surgery. And surgical treatment of choice will be TURP, transurethral resection of prostate. Right. So this is the same explanation which has been given here. So that will be available in the PDF format, जिसमें एक एक चीज को तार तार करके लिखा हुआ है. Right. Now this is an image based question. Yes, all the great doctors. Your eyes have to focus in this area. यहाँ पे कुछ है. Shubham, even if PSA is high, na, the game depends on the symptoms of the patient. Ha, if the PSA is say more than 10 and there is suspicion of cancer, then we'll go for prostatic biopsy. Right. Lovely. Okay. Okay. So hernia, you are absolutely correct. Inguinal hernia, yes, it is inguinal hernia. It is not femoral. Why it is not femoral, beta? Femoral hernia अगर होता तो गेम यहाँ पे होती बेटा, below and lateral to pubic tubercle. ठीक है. Now whether it is indirect or direct, देखते बेटा. Let's see the question. Okay. Wonderful. अच्छा बेटा, I'll wait for your answer, right? Okay. Okay, so Vedant has come up with the option Vedant Chill Life. Okay. Lovely. Good evening, Alisha. Aaron Shweta is saying direct. Shakib is saying indirect. Balaji is saying D. Dr. One is saying PM. Shakib, that is right. Saurabh is saying D. Okay. Avinash. Ajit is saying indirect. Now, beta, can you give me what is the Nand Kishore? Thank you, beta. Thank you so very much, Nand Kishore, for taking out your precious time. Please do send me a message on WhatsApp what you are doing nowadays. Okay, so apart from option D, GMR doctor has come up with PL, right? Okay. Rushik, Kshitija, Love, you're saying B. Umesh, Shivansh, Pailya, you're saying D. Rushik is saying PL. Okay, beta. So, Mansi cheating कर रही है बेटा. Sachin, thank you, beta. Thank you so much. Ajay is saying it passes through inguinal canal. Okay, बेटा. चले अब देखते बेटा इस गेम में खेल क्या है, वो how we have to play this game. So herein, let's read the last line. Based on these findings, which of the following is the most likely diagnosis as per EHS? Now बेटा ये EHS क्या है? तो EHS बेटा, they asked the question on EHS recently in the FMG exam. EHS is European Hernia Society. European Hernia Society classification. ठीक है ना बेटा? तो ये EHS क्लासिफिकेशन होता है. Oh, I'm so sorry. It's यूरोपियन हर्निया सोसाइटी क्लासिफिकेशन होता है. अच्छा, अब इसमें पहले तो हम ये देख लेते हैं व्हाट इज दिस स्टोरी. 45-year-old presents to OPD with a noticeable bulge in his right groin area for the first time in his life. Okay, beta, first time. That becomes more prominent when he coughs or strains. He reports that the bulge reduces spontaneously when he lies down. That means it is reducible, right? Bulge is located lateral to the lateral boundary of Hisselbeck's triangle. Okay, so see, this is how they can mix the integration, you can say. Now the Hisselbeck's triangle, beta, it is bounded by laterally by the inferior epigastric vessels, medially by the lateral border of rectus abdominis muscle, and below it is the inguinal ligament. And he's saying lateral to the lateral boundary of Hesselbeck's triangle. So beta, here are the inferior epigastric vessels. And if it is lateral to the inferior epigastric vessels, then it is coming out through the deep inguinal ring. And hernia which is coming out from the deep inguinal ring, usko indirect bolte hain, है ना बेटा? So this is the indirect inguinal hernia. And if the hernia comes out medial to the inferior epigastric vessels, that is a direct inguinal hernia through the Hesselbeck's triangle. और यहाँ पे गेम क्या हो रही है बेटा? This is lateral to inferior epigastric vessels, है ना? तो this is indirect inguinal hernia. ऐसे इसीलिए तो बोलते हैं बेटा कि inferior epigastric vessels act as a landmark to distinguish indirect from direct inguinal hernia, है ना? Now, अब if it is indirect, तो यूरोपियन हर्निया सोसाइटी क्या कहती है? EHS says कि भाई we can use various letters and numbers. For example, P and R. P पहली बार हुआ है, प्राइमरी. R बार बार होता है, रिकरेंट. तो वी कैन यूज P और R. यहां पे क्या हो रहा था बेटा? यहां पे इट वॉज पहली बार, तो इट विल बी P, राइट? देन वी कैन यूज लेटर्स लाइक L, M और F. L is lateral, M is medial, and F is femoral. So beta, lateral is indirect inguinal hernia. And in the given question it is lateral to inferior epigastric vessels. तो ये क्या हो गया बेटा? Indirect inguinal hernia के लिए अपन L लिख देते हैं. And if it would have been medial to the inferior epigastric vessels, we would have written it as M, है ना? And we can use some numbers like 1, 2, 3. That depends on how many fingers we can pass into the defect. जहाँ से ये हर्निया आ रहा है ना बेटा, उस छेद में कितनी उंगली जा रही है? If you are able to pass one finger in the defect, you write it as 1, 2 fingers in the defect 2, 3 fingers in the defect 3, and 1 European finger is equal to 1.5 centimeter, right? So if it is 1 number, then 1.5 centimeter defect, 2 number, then 3 centimeter size defect, and if it is 3 number, then 4.5 centimeter size defect, है ना बेटा? तो यहाँ पे गेम क्या बनी अपनी? So this will be primary and lateral. वंडरफुल बेटा. सुकांतो, अजीत, रूना. नाउ ये वाला जो क्वेश्चन है ना बेटा, इस पे बहुत ध्यान रखिएगा, बिकॉज EHS क्लासिफिकेशन हैज बीन आस्क्ड रिसेंटली. तो द एग्जामिनर माइट क्रिएट डिफरेंट टाइप ऑफ क्वेश्चंस रिलेटेड टू दिस EHS क्लासिफिकेशन, है ना? तो इसमें इट इज फॉर द फर्स्ट टाइम. सो it is lateral to the lateral boundary of Hesselbeck's triangle. That means lateral to inferior epigastric vessel, है ना? तो this is indirect. So the answer will be PL. ठीक है बेटा? And you have got all the things in the explanation यहाँ पे, right? Okay. पूरा इसको डिटेल में अच्छे से एक्सप्लेन किया है कि why this answer is correct, why this answer is not correct. जिससे कि if you are not watching the video, quickly you have to run through, so you can just go through the PDF as well, right? Okay बेटा, आगे चलते हैं. Now 16-year-old male presents to the emergency sudden severe pain in the right testis which began 4 hours ago. Okay, right testis में पेन है 4 घंटे से. Affected testis is swollen, tender, lies higher than the contralateral testicle. Cremasteric reflex is absent. Oh, so this is something which may be related to testicular torsion or maybe some infective pathology, epididyma orchitis. Now, in both testicular torsion and epididyma orchitis, we may find rubor tumor calloidolor, redness, swelling of the scrotum, pain in the scrotal area. But in testicular torsion, what happens, beta? There is thick spermatic cord, testis is pulled up, and cremasteric reflex is absent. Brand's test is negative, right? While in epididyma orchitis, elevation of the scrotum relief pain, that is positive Brand's test. Okay, so this might be a case of testicular torsion. Now he is saying what is the next best step in the management. Okay, ji. So if we are suspecting testicular torsion, beta, let me see what all the lovely doctors have answered. So majority of you are answering B, you are answering A, and then C. Okay. Okay. Right. Kushagra beta, 4 hours have already gone. Right. So time is very important. If the patient has come to you within 6 hours, then 80% of the testicle torsion testis can be saved. So we should do immediate scrotal exploration and should not waste time in getting any ultrasound or any Doppler done. Right. Like if you see the explanation here, testicular viability depends on time. Within 6 hours, 90 to 100% testis can be saved, though according to Bailey and Love, this is 80, more than 80%. 6 to 12 hours, only 50% testis would be saved, and after 12 hours, only less than 10% testis can be saved. So, why immediate surgical exploration? Because time is critical, right? Exploration will confirm the diagnosis, plus, you can derotate the testis and you can do bilateral orchidopexy. Why not ultrasound? Because it is useful but inappropriate when clinical suspicion is high. Delays definitive treatment. Scrotal support and antibiotics and all, no, nothing. So here the best answer will be immediate surgical exploration. You have to derotate the testis and do a orchidopexy. And for whatever reasons, if one testis has undergone torsion, you have to uh, keep on having this in mind that the other testis can also undergo torsion later on. So you have to do a contralateral orchidopexy for the normal testis also at the same sitting. Right. Yes, Indrajit, that's right. Okay. Now another question. Let's see. 40-year-old male presents with recurrent perianal pain and intermittent purulent discharge from a small opening near the anal verge. On examination, there is external opening located at 6 o'clock position. 6 o'clock. Okay, that is posterior. And on palpation reveals indurated tract. Best initial diagnostic test for this condition. What is this condition? Recurrent perianal pain. Okay. Intermittent purulent discharge from a small opening near the anal verge. Okay, so there is a opening near the anal verge. 6 o'clock position. Palpation indurated tracts. Okay, so this would be a case of fistula. That's right, Tony. Perfect. Perfect. Lovely. So big round of applause for all the great doctors watching this session, beta. Gold standard investigation for fistula and ano is MRI. That's absolutely correct. And why MRI, beta? उसके लिए कितना प्यारे explanation है बेटा here. Fistula in ano is a chronic abnormal communication between the epithelialized surface of the anal canal and the perianal skin, often secondary to infected anal gland, leading to abscess and subsequent tract. DRE is crucial but may not fully delineate the tract or its relation to sphincter muscle. Proctoscopy is helpful but lacks detailed imaging of the fistula tract. Fistulography is outdated and provides limited anatomical detail with poor sensitivity and specificity. MRI is the gold standard. It offers excellent soft tissue contrast and provides detailed information about the fistula tract, its relationship to the anal sphincter, and secondary extensions or abscesses. This is critical for preoperative planning to minimize recurrence and avoid sphincter injury. All the lovely doctors of this country who are watching this session right now, एक चीज याद रखना बेटा, फिस्टुला में फिस्टुला की गेम स्फिंक्टर से रिलेटेड है और किसी भी कीमत पे स्फिंक्टर डैमेज नहीं होना चाहिए. एनल स्फिंक्टर, we cannot damage somebody's anal sphincter. That is why before we treat these fistulas, it is imperative to know the relationship of this fistula with these sphincter muscle fibers so that we can save the anal sphincter. That is why MRI is the gold standard investigation. Right, beta? Okay, perfect. 68-year-old male presents with lower urinary tract symptoms, including increased frequency, hesitancy, and nocturia. Okay. Oh, so another question of BPH is coming up. His digital rectal examination reveals enlarged firm prostate with irregular nodules. Okay. Okay. Irregular nodules are there. Serum PSA is 15. Right. So you have already asked this question earlier, beta. See, the game here is same. The urinary symptoms, mild urinary symptoms are there, but PSA is high, more than 10, right? So we have gone for a biopsy, and biopsy confirms adenocarcinoma. So beta, this is a clear cut case of prostate cancer. Okay, so what is the most appropriate next step in the management? Okay, देखते बेटा, all the lovely doctors watching this session, Avinash, Ansya, Sawan, Rohit, Ayushi, Floaty, Indrajit, Pankaj, Parmar, Atul, Indrajit, everybody is saying B. Okay. Ajit is also saying radical prostatectomy. 68 का हो गया है सर, कुछ काम बचा है नहीं, निकाल दो. हाँ, एज लेस देन 70, GMR. Oh, so Inzamul has said D. Neetu is saying D. Okay. Krishna is saying B. Inzamul is saying D. GMR is saying D. Okay. So majority are saying B and few are saying D, and somebody has said A as well. Okay, beta. Let's see. So this is a case of prostate cancer. Now, till now what is mentioned in the question is that we have taken a biopsy and that is showing adenocarcinoma. Now what is the plan ahead? बायोप्सी में पता चल गया कि भाई ये प्रोस्टेट कैंसर है, ठीक है जी. सो इट इज अ प्रोस्टेट कैंसर ऑन बायोप्सी. अब नेक्स्ट स्टेप वुड बी मल्टी पैरामेट्रिक एमआरआई. अपने को एमआरआई करना पड़ेगा बेटा, स्टेज करना पड़ेगा, एंड देन अ पेट स्कैन, ये करना पड़ेगा. जब ये कर लेंगे बेटा, आफ्टर डूइंग दिस we'll be able to know whether it is a cancer which is confined within the prostate or it is advanced beyond the prostate. है ना बेटा? अब यहां पे गेम आएगी बेटा. नाउ बिकॉज दिस इज इंपॉर्टेंट, अगर इट इज कन्फाइंड विद इन द प्रोस्टेट तब गेम आती है इफ द एज इज लेस देन 70 ईयर्स, दैट इज लाइफ एक्सपेक्टेंसी मोर देन 10 ईयर्स, है ना, या एज इज मोर देन 70 ईयर्स, दैट इज लाइफ एक्सपेक्टेंसी लेस देन 10 ईयर्स. तब कैसे खेलना है? तब बेटा इफ इट इज लेस देन 70 ईयर्स तो यहाँ पे वी कैन डू रेडिकल प्रोस्टेटेक्टमी और वी कैन गिव एक्सटर्नल बीम रेडियोथेरेपी यूजिंग आयोडीन 125 या फिर पैलेडियम 103, है ना. बट इफ द एज इज मोर देन 70 ईयर्स देन वी डू एक्टिव सर्विलेंस. ठीक है ना. अब if the cancer has gone beyond the prostate beta, then even if you do a radical prostatectomy, you will not be able to remove complete cancer from this patient. So you have to just go with the palliative treatment. और palliation के लिए बेटा कैसे खेलना है? एंड्रोजन एब्लेशन करना है. एंड्रोजन एब्लेशन. एंड्रोजन एब्लेशन के लिए यू कैन आइदर डू मेडिकल और सर्जिकल. मेडिकल में बेटा यू कैन यूज LHRH एगोनिस्ट या एंटागोनिस्ट, जैसे गोसेरिलिन यूज कर सकते हैं अपन, है ना. और सर्जिकल में वी कैन गो फॉर बायलैटरल सब कैप्सुलर ऑर्किडेक्टमी कर सकते हैं. बायलैटरल ऑर्किडेक्टमी कर सकते हैं. राइट. अब देखते बेटा, है ना. तो ऐसे खेलना है ना बेटा. थैंक यू अविनाश. Oh, so we have seen the answer already. I'm so sorry. This is what is there in your workbook, beta. See, if the cancer is confined within the prostate, then basically अगर हम वहाँ से चलते हैं कि हमने बायोप्सी की, बायोप्सी में एडिनोकार्सिनोमा था, उसके बाद क्या करना है? उसके बाद MRI करना है, पैट स्कैन करना है, गैलियम 68 प्रोस्टेट स्पेसिफिक मेम्ब्रेन एंटीजन स्कैन, है ना, वो भी कर सकते हैं. अगर कैंसर इज कन्फाइंड विद इन द प्रोस्टेट, एज लेस देन 70 और लाइफ एक्सपेक्टेंसी मोर देन 10, देन रेडिकल प्रोस्टेटेक्टमी या EBRT विद आयोडीन 125 पैलेडियम 103. बट इफ एज इज मोर देन 70, लाइफ एक्सपेक्टेंसी लेस देन 10, देन एक्टिव सर्विलेंस. लेकिन बेटा अगर मान लो गेम जो है ये एडवांस हो चुकी है, तो पेलिएशन करना है एंड्रोजन एब्लेशन से. एंड्रोजन एब्लेशन के लिए क्या करना है, या तो मेडिकल या सर्जिकल. मेडिकल में वी कैन यूज एल एच आर एच एगोनिस्ट एंटागोनिस्ट, जैसे गोसलिन यूज कर सकते हैं. और सर्जिकल में बायलेटरल ऑर्किडेक्टमी करना है, बायलेटरल सब कैप्सुलर ऑर्किडेक्टमी. मेडिकल कैस्ट्रेशन इज बेटर. ठीक है ना, तो ऐसे खेलना है. अब यहाँ पे स्टेप्स क्या हुए, यहाँ पे नेक्स्ट स्टेप पूछ रहा है, व्हाट इज द मोस्ट अप्रोप्रिएट नेक्स्ट स्टेप. तो पहले अपने को क्या करना है, एमआरआई करना है. एमआरआई है क्या ऑप्शन में, यस, बोन स्कैन एंड एमआरआई पेल्विस इज देयर इन द ऑप्शन, राइट. दैट्स राइट बेटा, गोसरलिन, बोसरलिन ऑल्सो कैन बी यूज्ड, यस, राइट. थैंक यू बेटा. सो इसका आंसर हुआ अपना बोन स्कैन एंड एमआरआई पेल्विस. पहले ये करेंगे, उसके बाद फिर आगे बढ़ेंगे ना. ठीक है बेटा, चलिए जी. तो इसका पूरा डिटेल्ड एक्सप्लेनेशन व्हाट वी हैव डिस्कस्ड इज आल्सो गिवन इन दिस फॉर्मेट, राइट. चलिए बेटा. अच्छा अब ये बताओ बेटा, लेट मी नो द आंसर. This is the image based question, so we are seeing there is something here, and the options are Hurtle cells, pale orphan empty aniide nuclei, leaf like appearance, amyloid stroma. Okay. Last line of the question, most likely features seen on histopathological evaluation. Okay. Okay, so the answers are A, B, D. Uh-huh. बिट्टू, सिस्टिक हाइग्रोमा बहुत छोटू में मिलेगा. हम्म. अभिषेक, Namrata, Yeshu. Oh, so all of you are saying B beta. Then we'll just quickly read through it. 45-year-old female present with solitary thyroid nodule, increase in size over past 6 months. FNAC says papillary cancer. Oh, total thyroidectomy has been done. Most likely features seen on histopathological examination. Beta Hurtle cells, they are related to follicular thyroid cancer and in Hashimoto's. Pale orphan empty-eyed nuclei and samoma bodies, these are seen in papillary thyroid cancer. जो लीफ लाइक अपीयरेंस है बेटा, दैट इज इन सिस्टोसार्कोमा फाइलॉइडिस. सिस्टोसार्कोमा फाइलॉइडिस है ना. और फाइलॉइडिस ट्यूमर ऑफ द ब्रेस्ट. और एमाइलॉइड स्ट्रोमा जो है दैट इज सीन इन मेडुलरी थायराइड कैंसर, राइट. तो ये बेटा पेल ऑर्फन एम्प्टीआइड न्यूक्लियाई है. देखो किस तरह से ये खाली खाली न्यूक्लियाई है ना बेटा, राइट. एंड दीज आर सैमोमा बॉडीज. पीएसएम इसका न्यूमोनिक था, कुणाल सर ने आपको बहुत प्यार से बताया हुआ है पीएसएम, राइट. सीरस एडिनोमा ऑफ ओवरी, सलाइवरी एडिनोमास, मेनिंजियोमास, papillary thyroid cancer, papillary renal cell carcinoma, pituitary adenomas. So you find samoma bodies there, right? Okay. तो बेटा papillary cancer में we find pale orphan empty aniide nuclei and samoma bodies. You are absolutely correct. Very good, Neha. Right. Yes, Inzamol. And I would like to appreciate Inzamol and GMR doctor for giving the correct answer for the previous question. Wonderfully done. Right. Yes. Let's see. All the lovely doctors. Only easy question till now. Okay, beta. Floaty beam. Okay, let's take a look. What is the most appropriate initial treatment option for this patient? Okay, initial treatment option. Fine. Breast conserving surgery with adjuvant radiotherapy, neoadjuvant chemotherapy followed by mastectomy, total mastectomy with sentinel lymph node biopsy, hormonal therapy alone. Okay. Okay. 45-year-old female presents with a lump in her left breast. Core needle biopsy confirms it is invasive ductal carcinoma. ER/PR positive. Okay. HER2 new negative. No lymphovascular invasion. 2.5 centimeter lesion confined to the breast. No axillary lymph node. No metastasis. Okay, so let me see what is this 2.5. So if we just recall the staging of breast cancer, 2, 2 to 5, more than 5, any size, chest wall, skin, both, inflammatory. Lymph node staging, mobile, fixed, internal memory, axillary plus apical, axillary plus internal memory, supraclavicular and मेटास्टैसिस है ना बेटा. तो यहाँ पे स्टेजिंग देखते हैं बेटा. दिस इज 2.5 सेंटीमीटर. तो अप टू 2 इज T1. दिस इज 2 to 5. सो दिस इज T2. लिम्फ नोड नो एंड मेटास्टैसिस नो. Okay, so this is a game of this, right? Now beta, if we look at the treatment for breast cancer, for example, suppose we can classify these breast cancers into 3 categories, right? If I use this slide, right? Suppose I am using this slide beta for breast cancer. The games are early breast cancer. This can be T1 or T2, N0 or N1, and M0. There can be locally advanced breast cancer beta. This can be T3 or T4, N2 or N3, but M0. And then there can be metastatic breast cancer. Metastatic. Now in this there can be any T, any N, but M1. So here the game is this M1. Now what should be the ideal treatment beta? For early breast cancers, we can either do a breast conservative surgery, or we can do a simple mastectomy, or we can do a modified radical mastectomy, plus minus. If we are doing breast conservative surgery, then adjuvant radiotherapy will be mandatory, plus minus radiotherapy. If there would have been lymphovascular invasion, then we would have given chemotherapy as well. If hormone receptors are positive, like ER/PR were positive in this patient, so we would have given hormonal therapy. And hormonal therapy of choice in premenopausal females is tamoxifen 20 mg once a day for 5 to 10 years. Postmenopausal females, aromatase inhibitors and astrazoles. And if HER2 new would have been positive, then we would have given targeted therapy with trastuzumab, that is Herceptin or pertuzumab, है ना बेटा. तो ऐसे खेलना था. अगर ये locally advanced breast cancer होता, तो first we would have given new adjuvant chemotherapy to reduce the size of the tumor to achieve R0 resection. Then we would have gone with modified radical mastectomy. And then if needed, we would have gone for radiation or chemotherapy, or if hormone receptors would have been positive, then hormonal, or HER2 new gene positive, then targeted. And if it would have been metastatic, then if it would have spread to different areas in the body, then just a palliative treatment, maybe a simple mastectomy type, right? Now इस वाले patient में game क्या है? What is the game in this patient? It's a छोटा सा tumor. Early breast cancer वाली game चल रही है. Okay. तो if it is early, then we can do this. Now let us see the options. Neoadjuvant chemotherapy followed by mastectomy. No, this will be for locally advanced. Total mastectomy with sentinel lymph node biopsy. No. Hormonal therapy alone. No. The primary treatment will be surgery. So breast conservative surgery with adjuvant radiotherapy. And all the lovely doctors, you have already answered this correctly, beta. So the right answer will be breast conservation surgery with adjuvant radiotherapy. Here, this is the summary what is already mentioned in the workbook, what we have written earlier. And this is the prognostic classification where we know that if ER/PR are positive, it is good. If HER2/neu is positive, it is bad. Ki67 high is bad. Claudin low is bad. The best prognosis is luminal A, where ER/PR is positive, HER2/neu is negative, and Ki67 is low. And this is according to the latest guidelines, according to the latest edition of Bailey and Love. Right. Now, another question, beta. A 32-year-old male is brought to the emergency after road traffic accident. He is unconscious with GCS of 7. तो ये ध्यान रखेंगे बेटा, यहाँ पे GCS कितना है? 7 है. Okay. Now his pupils are unequal with the right pupil dilated and non-reactive to light. CT reveals epidural hematoma. What is the most appropriate next step? Right. नहीं बेटा सनशाइन, ऐसे घबराना नहीं है, हिम्मत नहीं हारना है. एक बार जब अपन रिवाइज करेंगे ना तो चीज़ें याद होने लगेंगी और फिर रिकॉल बेटर होने लगेगा. जब भी ऐसा कुछ होता है ना तो छोटा टारगेट ले लो, 20 मिनट का, 25 मिनट का, और ये सोचो कि इसमें मेरे को सिर्फ एक पेज याद करना है. जब वो पेज अच्छे से याद हो जाएगा ना तो वो कॉन्फिडेंस रीगेन हो जाएगा. GCS less than 7, so you are going to intubate. Okay. So Rajesh, Kamal, Runa, you are saying D. Majority of you are saying D. Few are saying C. Okay. होगा माइंडसेट बेटा, हारना नहीं है, रिकॉल होगा. तो अभी अपने पास 1 महीना है ना बेटा, तो 1 महीने में और मेहनत करेंगे. जितनी मेहनत अपने बस में बेटा उतनी मेहनत करनी है. रिजल्ट्स कभी अपने हाथ में नहीं होंगे. चिल लाइफ इज सेइंग सी. सो सी एंड डी में गेम चल रहा है. राइट. देख लेते हैं बेटा व्हाट इज दिस. दिस इज अ क्लियर कट केस जहाँ पे देयर इज सीवियर हेड इंजरी एंड एपिड्यूरल हेमेटोमा इज देयर. तो ऑब्जर्व एंड मॉनिटर ये तो नहीं करेंगे बेटा क्योंकि ऑलरेडी GCS इतना कम हो चुका है. IV मैनिटॉल एंड सीरियल CT स्कैन्स. मैनिटॉल में हेल्प इन रिड्यूसिंग द इंट्राक्रेनियल प्रेशर, है ना. ऑलरेडी इंट्राक्रेनियल प्रेशर इज़ वेरी हाई क्योंकि देखो प्यूपिल भी अनइक्वल रिएक्शन शो कर रही है ना. तो हो सकता है कि सेरेब्रल हर्निएशन हो रहा हो जिसकी वजह से अनइक्वल रिएक्शन आ रहा है. परफॉर्म इमीडिएट डिकम्प्रेसिव क्रेनिएक्टमी. यहाँ पे बेटा चिल लाइफ इस चीज़ को ध्यान रखना, यहाँ पे गलती नहीं करना. ये क्रेनिएक्टमी लिखा है, क्रेनिएक्टमी. देखो ये क्रेनिएक्टमी है, क्रेनियोटमी नहीं लिखा है. ठीक है, वो हो सकता है स्क्रीन पे उतना क्लियर नहीं आ रहा हो. राइट. एंड परफॉर्म एंडोट्रिकल इंट्यूबेशन एंड रिमूव द हेमेटोमा. ओके. कुशाग्र बेटा अगर EC नहीं आ रहा है तो दिन में 3 बार ईमेल करना है उनको. एक सुबह 9 बजे, एक 12 बजे और एक 3 बजे. याद से दिन में 3 ईमेल्स करना है डेली. हाँ, ब्लीडिंग अगर बहुत ज़्यादा हो तो मैनिटॉल इज यूज्ड विथ कॉशन. विल दे स्टिल नीड टू डू इंट्यूबेशन फर्स्ट? यस, इट्स अ सिवियर हेड इंजरी. तो बस बेटा उस चीज़ को ध्यान रखना था, है ना. तो क्रेनिएक्टमी नहीं करना है, क्रेनियोटमी करना है. क्रेनियोटमी करके वी हैव टू इवैक्यूएट द हेमेटोमा. राइट. सो आउट ऑफ द गिवन ऑप्शंस बेटा वी हैव टू डू एंडोट्रिकल इंट्यूबेशन एंड वी हैव टू इवैक्यूएट द हेमेटोमा. तो इसका जो करेक्ट आंसर होना चाहिए वो ये होना चाहिए. एंड एज वी नो कि जो एक्स्ट्रा ड्यूरल हेमेटोमा है इट लुक्स बाइकॉन्वेक्स हाइपरडेंस, बाइकॉन्वेक्स हाइपरडेंस, जबकि जो सब ड्यूरल होता है दैट इज कॉन्केवो कॉन्वेक्स. और यहाँ पे पूरा अच्छे से एक्सप्लेन किया गया है कि वाई दिस एक्सप्लेन वाई द अदर ऑप्शंस आर नॉट करेक्ट, है ना. तो GCS 7 सीवियर हेड इंजरी हो गया. अनइक्वल प्यूपिल मतलब इंट्राक्रेनियल प्रेशर बहुत ज़्यादा है जिससे हर्निएशन भी हो रहा होगा. एपिड्यूरल हेमेटोमा है, इट्स अ न्यूरोसर्जिकल इमरजेंसी, टाइमली इवैक्यूएशन इज क्रूशियल. Why not other options? Why not A? क्योंकि observation is contraindicated in severe head injury with clear signs of raised ICP. Mannitol and CT scan. Mannitol may temporarily reduce the ICP, but definite surgical intervention like hematoma evacuation is necessary. अब बेटा जो C और D में जो था, तो C में क्या है? Decompressive craniectomy is typically performed after consultation and with airway stabilization. पहले एयरवे को स्टेबलाइज करना ज़रूरी है. विदाउट इंट्यूबेशन इन अ कोमेटोज पेशेंट गोइंग फॉर क्रेनिक्टमी, नो. एंडोट्रेकियल इंट्यूबेशन एंड न्यूरो कंसल्टेशन, यस. इंट्यूबेशन पहले करेंगे, उससे क्या होगा? हाइपर वेंटिलेशन का मौका मिल जाएगा, तो आईसीपी रिड्यूस करने में हेल्प होगा. हाइपर वेंटिलेशन विल रिड्यूस आईसीपी एंड डेफिनेटली विल डू अ प्रोसीजर टू इवैक्यूएट द हेमेटोमा. सो आउट ऑफ सी एंड डी, डी विल बी अ बेटर आंसर, राइट? यस गणेश बेटा, इडली वाला इज बाइकॉन्वेक्स, राइट. तो इसलिए वी गो हेड विद डी, राइट. अब 25-year-old male is brought to emergency after high speed motor vehicle accident, complaints of severe chest pain. ध्यान देना बेटा जी कीवर्ड्स पे. यहाँ पे क्या लिखा है बेटा? सीवियर चेस्ट पेन एंड डिफिकल्टी इन ब्रीदिंग. ऑन एग्जामिनेशन डिक्रीज्ड ब्रेथ साउंड्स ऑन द लेफ्ट साइड. बिल्कुल गणेश, दैट्स राइट. सेरिब्रल एडिमा के लिए मैनिटॉल. ऑस्मोटिक डायरेटिक ऑफ चॉइस फॉर सेरिब्रल एडिमा, ब्रेन एडिमा इज मैनिटॉल. But in large intracranial bleeds, we have to use mannitol with caution because it can cross the blood-brain barrier, go into the bleed area and create that osmotic gradient and increase the size of bleed. Right. So all the lovely, lovely doctors, beta, Ajay, Nayan, Akshata, yes sir, Adil, Shivansh, all of you are saying B, okay? That means all the lovely doctors have got the keywords here. Indrajit, Medico, Runa, Saddam, Naresh, everyone is saying B. Perfect बेटा. क्यों आपने B बोला बेटा? क्योंकि ट्रेकियल डेविएशन दिख रहा है अपने को, है ना? तो ये हो गया, ट्रेकियल डेविएशन दिख रहा है, मिडाइसनल शिफ्ट दिख रही है, तो दिस विल बी अ केस ऑफ टेंशन न्यूमोथोरैक्स. डिक्रीज्ड ब्रेथ साउंड्स, this can be seen in simple pneumothorax or pleural effusion also. Hyper resonance can be seen in pneumothorax also. लेकिन ट्रेकियल डेविएशन अगर बोल रहा है और हाइपर रेजोनेंस बोल रहा है, दैट मीन्स नॉट ओनली इप्सिलैटरल लंग कोलैप्स बट बिकॉज ऑफ मिडनाइटल शिफ्ट अदर लंग इज ऑल्सो अंडर प्रेशर. सो इट इज अ केस ऑफ टेंशन न्यूमोथोरैक्स. अगर किसी ने दोनों गुब्बारे दबा दिए हैं, बोथ द लंग्स आर अंडर प्रेशर, तो definitely patient is having severe difficulty in breathing, respiratory distress. We do not have the time to put the tube. We have to immediately put a wide bore needle in the fourth or fifth intercostal space, just anterior to mid-axial line in adults, second intercostal space in mid-clavicular line in children. And then once we get 10, 15, 20 minutes, we have got time to put the intercostal tube drainage, right? Okay, so as you have rightly pointed out, this is tension pneumothorax, and this is a wonderful explanation also, Vita, which is given here. So when you will be reading the PDF, this is the same story. Why not the other options? Hemothorax will present with dullness, not hyperresonance. Flail chest, there will be paradoxical movement, and pulmonary contusion, there will be alveolar hemorrhage and not hyperresonance or tracheal deviation. Right. एक व्यक्ति जिसने कभी गलती नहीं की बेटा, उसने कभी कुछ नया करने की कोशिश नहीं की. तो आप कह रहे थे ना बेटा कि नहीं याद रह रहा है, रिकॉल नहीं हो रहा है, गलतियां हो रही हैं. साहिल, मैं काफ़ी दिन के लिए बाहर गया था बेटा, जगह जगह पे, किर्गिस्तान, उज़्बेकिस्तान, रशिया, वहाँ भी बच्चों से मिलने का मौका मिला एंड दे वर रियली लवली. प्यारे प्यारे से छोटे छोटे से बच्चे, उतनी ठंडी में दे आर ट्राइंग टू बिल्ड अप देयर करियर. तो बड़ा अच्छा लगता है बेटा सबसे मिलके, राइट. सो बस हिम्मत रखना है बेटा अपनी, है ना, हारना नहीं है. गलतियां होंगी, दे आर बाउंड टू हैपन, उससे हारना नहीं, लड़ना है. डेली बेसिस पे अपने को हिम्मत देनी है कि मुझे डेली बेसिस पे कुछ ना कुछ अच्छे से याद करते हुए आगे बढ़ना है. राइट बेटा. So 25-year-old male is brought to emergency after a road traffic accident. He complains of severe abdominal pain. On examination, थोड़ा सा लेंदी सा लग रहा है शायद ये. इज टेकिकार्डिक, हाइपोटेंसिव, एब्डोमिनल गार्डिंग रिजिडिटी, फास्ट पॉजिटिव. नेक्स्ट बेस्ट स्टेप देखते बेटा. कंप्लीट योर सर्जरी फर्स्ट बेटा फ्रॉम द वर्कबुक शिवांगी. राइट, एक बार रिवीजन वीडियो देख लिया, 2x पे देख लो उसको, 3 से 4 घंटे में उसको क्लोज करो शिवांगी, एंड देन लर्न दी वर्कबुक नाइसली. अगर वर्कबुक अच्छे से याद होगी बेटा तो रिकॉल वुड बी ग्रेट. ओके डॉक्टर डोपामिन बेटा, आई डेफिनेटली कम. Okay, so all the lovely doctors, you are answering it as C. A few Mohammed and Yesh have answered B. Okay. थैंक यू किरण बेटा, थैंक यू सो मच. कैसे खेलना है बेटा यहाँ पे? देखो इसमें गेम क्या हो रही है, दिस इज अ रोड ट्रैफिक एक्सीडेंट स्टोरी, है ना. कीवर्ड्स क्या क्या हो गए इसमें? टेकिकार्डिया हो गया, बीपी 90-60 हो गया, यानी कि अच्छा खासा ब्लीड हो रहा है. शॉक इंडेक्स इज मोर देन 1. पेशेंट इज हीमोडायनेमिकली अनस्टेबल. साथ में बोल रहे हैं एब्डोमिनल गार्डिंग रिजिडिटी है, हो सकता है देयर माइट बी परफोरेशन ऑल्सो. फास्ट पॉजिटिव है, फास्ट में फ्री फ्लूइड है. नेक्स्ट बेस्ट स्टेप पूछ रहा है, पेशेंट अनस्टेबल है. अगर अनस्टेबल है बेटा तो क्या सीटी करेंगे बेटा अनस्टेबल पेशेंट में? विल यू डू अ सीटी स्कैन इन अ हीमोडायनेमिकली अनस्टेबल पेशेंट? नेहा, यू आर परफेक्टली राइट. हाइपोवॉल्यूमिक शॉक है आदि, बिल्कुल ठीक है बेटा आदि. ब्लू पैंथर, यस, परफेक्ट. सो मेजॉरिटी हैव यस, फिल द डॉक, खोल दो. जब पेशेंट बिल्कुल ऐसी हालत में है, वी विल ट्राई टू रिसस्टेट दिस पेशेंट अनडाउटेडली. वही ABCD वाली गेम खेलनी है. इफ डिस्पाइट पंपिंग इन IV fluids, blood transfusion, Trenexa, the patient is not getting stabilized, then because the game is like this, doing a diagnostic peritoneal lavage, this has become obsolete now. CT unstable patient है भाई, अगर CT के लिए भेज दिया तो ये तो CT रूम से ऊपर चला जाएगा. We don't have time to get a CT done. Immediately open laparotomy. IV fluids देना है, that is the first thing. लेकिन उसके बाद ऑब्जर्व करना है, ये चीज़ गलत है. यहाँ पे ऑब्जर्व नहीं करना है. अब नाउ इफ वी सेग्रीगेट, ये अपने वर्कबुक में देखो ऐसा लिखा है कि ब्लंट एब्डोमिनल ट्रॉमा का पेशेंट है तो कैसे खेलना है अपने को. अगर पेशेंट वॉज स्टेबल, देन वी वुड हैव एडमिटेड द पेशेंट फॉर ऑब्जर्वेशन. फर्स्ट वी वुड हैव डन ई फास्ट, बिकॉज द पेशेंट वुड हैव बीन स्टेबल, सो वी हैव डन CCT, एंड देन जनरली द ट्रीटमेंट इज कंजर्वेटिव, दैट इज नॉन ऑपरेटिव. लेकिन अगर पेशेंट अनस्टेबल है तो फर्स्ट वी हैव टू सेव द लाइफ. ABCD, E fast कर लिया, राइट, एंड देन इमीडिएट लेप्रोटमी बाय मिड लाइन इंसेशन. और अगर इट वॉज ब्लीडिंग एक्टिवली तो वी कैन टेक द हेल्प ऑफ दिस Pringle maneuver also. We can take the help of Pringle maneuver also if it is bleeding profusely. So we put our thumb index finger in the foramen of Winslow hepatoduodenal ligament to clamp the portal vein hepatic artery. है ना, राइट, परफेक्ट बेटा. तो यहाँ पे इसका एक्सप्लेनेशन भी अच्छे से लिखा हुआ है. वाई नॉट DPL? क्योंकि DPL इज इन्वेसिव, प्लस इट इज यूज इन स्टेबल पेशेंट्स, नॉट अनस्टेबल पेशेंट्स, दो इट हैज बिकम ऑब्सोलीट ऑलरेडी. CT के लिए टाइम नहीं है बेटा. IV फ्लूइड देना है, बट ऑब्जर्वेशन इज कॉन्ट्रा इंडिकेटेड इन अनस्टेबल पेशेंट विद साइंस ऑफ पेरिटोनाइटिस और ब्लीडिंग. इमीडिएट सर्जिकल इंटरवेंशन इज नेसेसरी टू कंट्रोल द सोर्स ऑफ ब्लीडिंग. राइट, ठीक है. तो इसमें जो आंसर हो गया अपना emergency laparotomy. Wonderful. Yes. 35-year-old male presents to emergency, burns covering 40%. Okay. Partial thickness burns to his torso and upper limbs. ठीक है जी. तो he has already mentioned 40%, तो फिर इस पे फोकस करने का वो नहीं है. Heart rate is 120, BP 90-60, respiratory rate 25. Oh my god. तो यहाँ भी patient is in hypovolemic shock. He complains of severe pain. What is the most appropriate initial step? Okay बेटा, patient is in hypovolemic shock, है ना? Pipeline में pressure नहीं है. Oxygen supply to the vital organs is going down. Patient can die. Who are you? You are the second god. You cannot allow your patient to die. To save the life of this patient, you want oxygen supply in the vital organs. That means you have to generate pressure in the pipeline. And to generate pressure in the pipeline. Lovely. Salute to all of you, beta. And this is what I want from all the lovely doctors, that please do not forget to maintain or generate pressure in the pipeline whenever the oxygen supply is going down to the vital organs. This will save the life of your patients. Wonderful. Big salute to all the great doctors. Great. So obviously, if the pressure in the pipeline is less, why we'll be thinking of giving antibiotics or grafting or silver sulfadiazine? We have to supply oxygen to the vital organs. Right. So you're perfectly right. Ring elected, that's absolutely correct. Perfect, beta. Right. And here all the detailed explanation is also given. Right. 60-year-old male presents with history of progressive pain in the lower limbs on exertion, which resolves with rest. Okay. Progressive pain in the lower limbs on exertion. Okay. Resolves with rest. Okay. मतलब चलने पे दर्द हो रहा है, रेस्ट पे ठीक हो रहा है. ओके. ही ऑल्सो कंप्लेन्स ऑफ कोल्डनेस, डिस्कलरेशन ऑफ द टोज. ओके. मतलब ऑक्सीजन सप्लाई, आर्टीरियल सप्लाई कम होगी चलने पे. Examination reveals reduced, oh, he has already said, reveals reduced dorsalis pedis and skin changes consistent with chronic ischemia. Okay. First line treatment for this condition. So beta, this game is a gradual arterial obstruction game. जहाँ पे the game starts with intermittent claudication, which is calf pain on walking a certain distance, and the distance which the patient is able to walk, that is called as claudication distance. और इसकी Boyd's grading है ना बेटा. Calf pain on walking improves on further walking. This is grade 1. Calf pain on walking, patient continues to walk with pain. This is grade 2. Calf pain on walking, but now the pain is so severe that he cannot walk any further. He has to take rest. This is grade 3. And grade 4 is rest pain. Rest pain is felt in the foot, even at rest. Then there will be coldness, numbness, paresthesia, pre-gangrene and gangrene. This is atherosclerosis, Indrajit. Absolutely correct. Fildi, you're saying less than 0.9. You're absolutely correct. Boyd, 3 OVR Rajput, perfectly right. Atul, everyone beta. Now let's see what will be the treatment. So he's asking what is the first line treatment for this condition. Okay. So how to play this game beta? Initial stage pe patient aaya hai. We have got 4 options in the treatment. First, lifestyle, then medicines, then angioplasty, and then bypass surgery. Right? तो अगर यहाँ पे देखते हैं, if you see your workbook, treatment of gradual arterial obstruction, lifestyle modification, medicines, then angioplasty, and then bypass surgery. और bypass में बेटा, for coronary artery bypass we use Lima, है ना? जबकि femoropopleteal bypass के लिए we use long saphenous vein. ठीक है बेटा. तो इनिशियली कैसे खेलना है? इनिशियली लाइफस्टाइल मॉडिफिकेशन, उस पे जाना है. और फिर उसके बाद मेडिसिन में एंटीप्लेटलेट्स कैन बी यूज्ड. लॉन्ग टर्म के लिए एस्पिरिन, शॉर्ट टर्म के लिए क्लोपिडोग्रेल. statins can be used if it is atherosclerosis game, and vasodilator cilostazol, oxypentyphylline can also be used. तो इधर जो गेम होगा बेटा, दैट इज एंटी प्लेटलेट थेरेपी एंड लाइफस्टाइल मॉडिफिकेशन. अगर इनसे बात नहीं बनती है, देन वील गो फॉर एंजियोप्लास्टी, एंड देन वी कैन इवन थिंक ऑफ अ surgical revascularization using a bypass graft. If the game would have been gangrenous, then we would have gone for amputation. Right. Lovely, all the lovely doctors, beta. Wonderful. So this is a detailed explanation given here. Right. Now let's see. All the lovely doctors, let me just switch myself off and let's see your answer. Yes, Adik. Sometimes the questions are really tough in the current pattern of exam. Let's see. Elias is saying A. Indrajit saying varicose. Thank you, beta. Thank you, emergency docs. Thank you so much. Shweta is saying A. Parmar is saying B. So the game is going between A and B. A and B confusion. Okay, Atul. Let us try to segregate it. Okay. Now aesthetic is saying DVT. Sir is saying yes, he's the teacher. So he's standing whole day. A, C, B. Okay, let's see. This is a lengthy question. So let's read the last line. Most effective treatment. Most effective treatment he's asking. Compression stockings lifestyle modification, sclerotherapy, thermal ablation, and surgical ligation and stripping. Actually, if you see all these four options, these are the treatment for varicose veins. All the four options, right? Now, 45-year-old teacher presents with complaint of visible tortuous veins, aching pain after prolonged standing, dilated superficial veins, and skin discoloration over the medial malleolus. So, beta, skin discoloration over the medial malleolus. That means this is lipodermatosclerosis. That means it is not just varicose veins, but complications have started appearing of varicose veins, lipodermatosclerosis. Trendelenburg test is positive. That means there is some saphenofemoral incompetence, valvular incompetence, and Doppler also confirms the reflux in the great saphenous vein. We know, beta, that suppose this is the femoral vein, and suppose here is the great saphenous vein. There is a valve at the junction of saphenous vein and the femoral vein. In prolonged standing cases, this valve, because of back pressure, this valve gets damaged. And if this valve gets damaged, then blood from the femoral vein will start flowing into the great saphenous vein. And this is going to make the great saphenous vein abnormally dilated and tortuous. And because the most dependent part is around the medial malleolus, so maximum pooling of blood will be around the medial malleolus, which can cause lipodermatosclerosis or venous ulcers here, right? Initially, we do lifestyle modification where we advise the patient not to keep on standing for long periods. Whenever he's lying on the bed, he is asked to raise his legs, keep a pillow under the legs, and elastic compression stockings. But if the patient has got severe symptoms or any of the complications, maybe lipodermatosclerosis or venous ulcers, or maybe champagne glass appearance, or maybe Marjolin's ulcer, or maybe squamous cell carcinoma type of stories, then we have to treat. And in the treatment, we have the options of sclerotherapy, endothermal ablation using radiofrequency or laser, or maybe surgery like Trendelenburg operation and stripping of the varicose veins, right? Out of all these, sclerotherapy, thermal ablation, and surgery, endothermal ablation is the recommended treatment of choice because it is less invasive, can be done quickly, and patient has less morbidity and wonderful results. So endothermal ablation is the most effective treatment nowadays, right? Okay, let's see. So here the answer will be endothermal ablation, that is thermal ablation therapy. This is what we know, that the investigation of choice for varicose veins would be duplex imaging. And in the early stages, we do conservative treatment, but late stages, the gold standard treatment is endothermal ablation using laser or radio frequency. एंड दिस इज़ अ नाइस एक्सप्लेनेशन बेटा. यहाँ पे पूरा एक एक बारे में लिखा हुआ है कि विच ऑप्शन इज़ करेक्ट एंड विच ऑप्शन इज़ नॉट करेक्ट, व्हाट इज़ द रीज़न. तो कंप्रेशन स्टॉकिंग्स जो है, दिस इज कंजर्वेटिव, रिकमेंडेड फॉर माइल्ड केसेस और पेशेंट्स अनफिट फॉर इंटरवेंशन. Sclerotherapy, we are giving sclerosing agent. It is unsuitable for large veins with significant reflux. Thermal ablation is the first line treatment for symptomatic varicose veins due to minimal invasive, high efficacy and low complication rates. It also targets the refluxing vein, leading to closure and symptom relief. Surgery is now reserved for cases where endovenous ablation is contraindicated or unavailable, as it is more invasive and associated with longer recovery. So thermal ablation therapy is the most effective treatment, right? Now, 32-year-old lactating woman presents with rubor tumor dollar in the right breast for the past 5 days. 5 दिन से right breast में acute inflammation के signs हैं. On examination, there is a tender fluctuant mass in the lower outer quadrant. Tender fluctuant मतलब इन्फ्लेमेटरी गेम है 5 दिन से और फ्लक्चुएंट स्वेलिंग है, तो एब्सेस हो सकती है. शी इज फेब्राइल विद अ टेम्परेचर ऑफ 38.5 डिग्री सेंटीग्रेड. मोस्ट अप्रोप्रिएट मैनेजमेंट. ओके बेटा, देखते हैं. राइट, सो we have received the answers as B, A, C. Okay. Runa Parmar is saying B. Suyesh is saying D. Okay. B, A, C. This is going on. Okay. Indrajit is saying continue breastfeeding. Insulin and drainage, Ajit. And antibiotics, yes. Okay. So let us just try to figure out better. If we just see that pregnancy and lactation during breastfeeding, the staph aureus from the baby's mouth can travel through cracks in the mother's nipple and go inside the mother's breast. And mother's breast is engorged with milk. तो पार्टी इनसाइड द ब्रेस्ट है ना, तो दैट कैन लीड टू मेस्टाइटिस. अब बेटा यहाँ पे गेम क्या है? अगर गेम सिर्फ मेस्टाइटिस की है तो दैट मीन्स द गेम वुड बी सिंपली रूबर ट्यूमर कैलर डॉलर, रेडनेस, स्वेलिंग, रेज टेम्परेचर एंड पेन, ये होगा. अगर पेशेंट इस स्टेज पे अपने पास आती है तो स्टैफ को मारने के लिए एट दिस स्टेज वी हैव टू गिव एंटीबायोटिक्स एंड ब्रेस्ट सपोर्ट देना है ना बेटा. लेकिन if the patient is shy and has not reported to us and suppose the party of staph continues inside the breast, तो patient may develop early stage of breast abscess, जहाँ पे क्या हो सकता है बेटा? multiple tiny pus pockets, छोटी छोटी पस की pockets inside the breast. अगर मल्टीपल टाइनी पस पॉकेट्स हैं बेटा तो फ्लक्चुएशन होगा कि नहीं होगा? फ्लक्चुएशन विल बी नेगेटिव. ऐसे केस में कैसे खेलना है बेटा? एंटीबायोटिक्स भी देना है और अल्ट्रासाउंड गाइडेड मल्टीपल नीडल एस्पिरेशन करना है. अल्ट्रासाउंड गाइडेड मल्टीपल नीडल एस्पिरेशन करना है, ठीक है. लेकिन अगर पेशेंट डज नॉट कम टू अस इवन एट दिस स्टेज, तो लेट स्टेजेस ऑफ ब्रेस्ट एब्सेस में क्या होगा? वी मे फाइंड अ नाइस फ्लक्चुएंट मास और फ्लक्चुएंट स्वेलिंग इनसाइड द ब्रेस्ट. अल्ट्रासाउंड पे वील सी गुड लिक्विड कलेक्शन इनसाइड द ब्रेस्ट. एंड ऑल द लवली डॉक्टर्स नो पस, localized collection of pus anywhere inside the body has to be drained without spillage. So along with antibiotics, ultrasound guided कैथेटर ड्रेनेज. पहले क्या करते थे इसके लिए? एंटीबायोटिक्स विथ इंसिजन एंड ड्रेनेज करते थे, है ना. तब रेडियल इंसिजन यूज टू बी द बेस्ट एंड पेरिएरुलर यूज टू बी कॉस्मेटिक. बट अभी अल्ट्रासाउंड गाइडेड कैथेटर ड्रेनेज एंड द कैथेटर इज कनेक्टेड टू अ वैक्यूम सक्शन ड्रेन. ये जो दिख रहा है ना बेटा अपने को, दिस इज अ वैक्यूम सक्शन ड्रेन, है ना, रोमोवैक के नाम से जो आता है. ठीक है बेटा. फ्लक्चुएशन मीनिंग बेटा सनशाइन, इफ any swelling which has got liquid collection on one side, if you put one finger on one side of the swelling and try to press another finger on the other side of the swelling, now you can feel the fluid pressure on the other finger if you try to press from one side. That is fluctuation. Okay, right beta. तो out of the given options, सिर्फ एंटीबायोटिक कब देंगे? जब सिर्फ मेस्टाइटिस होता. यहाँ पे तो उसने फ्लक्चुएशन लिखा हुआ है, तो अगर फ्लक्चुएशन लिखा हुआ है तो इट इज़ अ लेट स्टेज ऑफ ब्रेस्ट एब्सेस, ये वाली स्टेज है. इसके अलावा बेटा इमीडिएट अल्ट्रासाउंड गाइडेड कैथेटर ड्रेनेज, हाँ वी कैन डू अल्ट्रासाउंड गाइडेड कैथेटर ड्रेनेज, क्योंकि फ्लक्चुएंट है तो अल्ट्रासाउंड गाइडेड कैथेटर ड्रेनेज कर सकते हैं. स्टॉप ब्रेस्ट फीडिंग एंड स्टार्ट एंटीबायोटिक्स, नहीं बेटा, ब्रेस्ट फीडिंग को स्टॉप नहीं करना है, क्योंकि इफ यू स्टॉप ब्रेस्ट फीडिंग देन मिल्क विल रिमेन इनसाइड द ब्रेस्ट ओनली and will further lead to breast engorgement, further chances of infection. So breastfeeding should be continued. Fine needle aspiration and follow-up, nahi beta. We have already discussed this. So I think out of the given options, kya sahi hua beta? You have rightly mentioned out of the given options, kyunki it's a fluctuant swelling, so we'll do ultrasound guided catheter drainage. Monishkar beta, if we are making a transverse incision, it will definitely cause significant damage to the ducts. So we are making a radial incision. लेकिन why we are preferring ultrasound guided catheter drainage over incision drainage? क्योंकि if we are making incision drainage ना, then we have to put the dressing over the breast, and patient will not be able to breastfeed the baby. Plus this will also give a big scar to the patient, right? तो इसलिए if we can do ultrasound guided catheter drainage as shown in the picture where it was connected to vacuum suction drain, that is a better option, right? And so now this is a summary given for what we have discussed. Now coming to the last question for today beta, let's see. If pus still forms after 2 USG guided beta, we have put a catheter Neha into that na. So catheter will continuously keep on draining whatever pus is being formed. We can flush that catheter if that catheter is getting blocked with thick pus. Right. So the last question for today beta, let's see. All the lovely doctors, इस देश के इतने बड़े डॉक्टर्स जो आज अपना कीमती समय निकाल के इस सेशन को देख रहे हैं बेटा. "22-year-old female presents with painless mobile lump in her right breast that she first noticed 6 months ago. On examination, lump is firm, well circumscribed and approximately 2 centimeter." ओके, तो एक तो 22-year-old है, 2 सेंटीमीटर की मोबाइल लंप है. ओके, तो कॉमनेस्ट बेनाइन ब्रेस्ट ट्यूमर वी ऑल नो. अल्ट्रासोनोग्राफी कंफर्म सॉलिड हाइपोइक्विक लीजन, स्मूथ मार्जिन्स है, स्मूथ है, तो मोस्ट लाइकली इट शुड बी फाइब्रोएडिनोमा. मोस्ट अप्रोप्रिएट मैनेजमेंट पूछ रहा है. 22 ईयर्स पे कैसे खेलना है बेटा? अब दो ऑप्शंस आ रहे हैं यहाँ पे, ए एंड सी. यस, ब्रेस्ट माउस, एब्सोल्युटली करेक्ट बेटा इंद्रजीत. 2 सेंटीमीटर, सो ऑब्जर्वेशन अजीत. मेजॉरिटी ऑफ यू आर सेइंग ए. ओके, and you are absolutely correct beta. So let's have a big round of applause for all the lovely doctors. You have answered it correctly. Why the other options are not correct? Like here, if you see, core needle biopsy and immediate surgical excision is not warranted unless malignancy is suspected. Wide local excision sentinel lymph node biopsy is used for breast cancer, not fibroadenoma. And total mastectomy is unnecessary for a benign lesion like fibroadenoma. Perfect beta. So what I've tried to do in this uh, 25 most important questions series, beta. I have tried to summarize the explanation for the given answer. Plus, I have also tried to summarize in writing format that why this option is not correct, why the other option is correct. So I would really like to thank all the lovely, lovely doctors. And I would like to remind all of you, beta, that you are not alone in this journey. The entire team of MIST is standing behind you. And always remember that you are going to be a winner. We know that you are playing with fire. सफ़र लंबा है, चढ़ाई है, लेकिन हारना नहीं है बेटा. आपने जो MBBS करते समय चैलेंजेस फेस किए हैं, उन चैलेंजेस को हर बार याद करना बेटा. Many of you might have faced lot of situations where you would not have been comfortable, but you would have kept your patience, you would have kept your mind open, you have used your common sense, and you would have been able to come out of those tricky situations. If you have done lots and lots of sacrifices by fighting with so many things in your life in the last 5 to 6 years, please do remember, along with you, your parents also have made lots and lots of sacrifices in your journey. So beta, if you know that how we have to win this game, you know what content you have to learn, which MCQs you have to revise, you know that. Now, our duty is, let us try to learn that content nicely. Let us try practicing few MCQs on a daily basis in this last 1 month so that we know how to apply our knowledge. Because it is not only our sacrifices, but our parents' sacrifices are also involved. Then we'll definitely do extremely, extremely, extremely hard work and let nobody come in between our hard work and our parents' dreams. Let us prove to this entire world what we are capable of. And let me remind all the lovely foreign medical graduates that you are no less than anyone on this earth. You have got great power, you have got great personality, you have got everything, every firepower inside you to change the mindset of everyone. And you're definitely going to do it by your consistent hard work. May God bless you all, and may each one of you come out with flying colors and prove to the entire world what you are capable of. You will do it. Thank you very much. May God bless you, and may you realize your parents' dreams. Thank you so much.